won't moan and I won't beg. Oh, if I ever lose my legs, oh, if I won't have to walk no more. And if I ever lose my mouth, all my teeth, north and south. Yes, if I ever lose my mouth, oh, if I won't have to talk. Did it take long to find me? I asked the faithful light. Oh, did it take long to find me? And are you gonna stay the night? I'm being followed by a moon shadow, moon shadow, moon shadow. Leaping and hopping on a moon shadow, moon shadow, moon shadow. Moon shadow, moon shadow.
Is the mic working? No mic. Is that better? That's better. Okay, I'll move it closer. All right, good morning again, everybody. We'll go ahead and get started. I'm excited to be here with you this morning. Do we have Dr. Kelly? I don't know if Dr. Kelly is online, but we'll go ahead and get started. All right, so first of all, I wanted to ask if you can please join me in recognizing Dr. Kelly for all of her service and leadership on the Lung Committee. She has really been a pillar for this committee over many, many years, I think much more than a lot of us realize, and we want to wish her all the very best on her next journey. She has really helped to lay the foundation from which we will continue to work together and work toward excellence for all of our patients battling lung cancer. So let's go ahead and give Dr. Kelly a round of applause, please. And I'm going to ask if Dr. Kelly is online and would like to say a few words, please.
Hi, good morning. I am here. Thank you so much, Janelle. I just want to say that it has been a privilege of a lifetime for me to be the SWOG Lung Committee Chair. I'm very proud of what we've all accomplished together. And I know that under Janelle's leadership, we'll continue to accomplish great things to help our patients. Thank you.
Oh, thanks again so much, Karen. And we look very forward to continuing to work with you very closely. Thank you. All right, we'll go back to the slide deck. Perfect. All right, so, I started in this role on April 1st and having this first meeting. So I want to take a moment to thank everybody who's met with me, started having some one-on-ones and hearing your voice. I also want to thank everybody that rallied to help get this meeting together. It is no small feat to do it in a very short period of time. So I just thought I would take a couple of moments just to talk you through what my vision is for the Lung Committee moving forward. And one is to really, again, that foundation that has been laid by Dr. Gandera, by Dr. Kelly in the past, as well as many of those in this room, is to continue to usher in those new therapies for all of our patients battling lung cancer. Another key thing is really, focusing on how do we reach broad, diverse patient populations. We really have an opportunity within SWOG and within our network of sites to reach patients, all sorts of patients, right? And bring those trials to those patients. LungMap, Ray and I were just talking about how LungMap has really set us up for a lot of success, and what can we do to learn from lessons learned, and what can we do to build upon that throughout the entire committee. And also, mentoring is very, very important to me. This is a passion of mine. I think we can all say, everybody, and a lot of us in the room wouldn't be where we are without somebody mentoring us. And many of us still have mentors. And so, it's really about cultivating the careers as well as the ideas of our junior faculty, including our underrepresented minorities. What I've asked in all of the other committee meetings is asking everybody to recommend a junior investigator from their site to come be involved in the lung committee. Please send me their email and their contact. I'd love to meet with them, one-on-one. All right, and with that, I'll move on. So this is the agenda. It's a packed agenda. I know a lot of people have flights to catch, including me. We're going to highly encourage all of the speakers to stay on time. We're going to batch some of these sessions together and hold questions to the end. So we'll do all of the subcommittee updates, run through those, and then maybe hold questions to the end, and then we will invite our scientific speaker up, and then go through the medical oncology trials, and then our second scientific speaker. All right. Okay, so one of the things we have been doing, and SWOG has done an excellent job of not only opening trials, but also completing them. And now we have multiple submissions at AACR. We've had multiple submissions at ASCO, and I do want to congratulate the stat and thank the stats team for getting all of this together. I don't know if you guys know, but a lot of the deadlines for ASCO, AACR, and World Lung, which you'll see on the next slide, were very, very close together. So they were working extremely hard in the background to get this all done. And so thank you. Let's give a round of applause to Mary Redmond and her team, please. And if you're on her team in the audience, if you could please raise your hand or stand up also so we can see. Oh, they're not here. Okay. Well, they were in the other meeting. Mary,
They might be online. So,
are you on? Yes. Okay.
so Katie Minichello,
Perfect.
Jailing Mao, those are main statisticians, and then also Xing Hua and Mike Wu were involved with a lot of the TM work too. So
Wonderful. Well, thank you guys for all of your hard work. I also want to congratulate Dr. Karen Rettkamp and her team on the 1800 ACE trial, S1800A trial from the lung map. And this got an oral presentation, so highly encourage you to attend that and see the exciting data. Some really great work coming out from the lung committee and lung map. Okay, and so with that, I will ask Judy Johnson to kick us off this morning with the patient advocate update. Judy, I believe you are joining us virtually.
That's right.
All
Can
right,
you hear me okay?
Yes, we can hear you very well. Just let me
Okay.
know and I will advance the slides for you.
All right. I can't see anybody and you probably can't see me, but I can talk to you. So thanks for this opportunity to give you an update. I really appreciate it. And I've enjoyed very much my 5 years on this committee, working with Dr. Kelly and now Dr. Gray. It's one of the most exciting things I've done in my career. So thank you for this opportunity. You can advance. Here are my topics for this morning. You can advance. So here we are, SWOG patient advocates, passionate, hardworking people with a common goal: to represent the voice of cancer patients in the design, development, and implementation of clinical trials. We have 22 research advocates like me who focus on clinical trial development, and we're embedded in committees like the Lung Committee. We also have 10 community advocates who work across SWOG committees, representing communities like LGBTQ, rural patients, and young adults. You can advance, please. Next slide. So here's a look at my SWOG advocacy roles, all springing from my membership in the Patient Advocate Committee. Next slide. A significant part of my time is spent on study development and implementation, as you all know. Collaborating with study teams and SWOG's outstanding staff throughout the clinical trial lifecycle is the foundation of my work. Next slide, please. Within LungMap, a substantial part of my work also happens early in the clinical trials lifecycle. Creating patient-friendly informed consent documents is my top priority. The Accrual Enhancement Committee, which some of you heard from yesterday, members work to increase awareness and enhance accrual for the LungMap sub-studies. We recently hosted an advocates webinar to give them an update on where we've been and where we're going. And we will be having these webinars quarterly to ensure that we actively engage and communicate with the patient advocacy community. Next slide. You'll hear more about this committee from Dr. Hesketh later in the meeting. I serve as their advocate member and support initiatives like these, and also participate in our monthly teleconferences. Next slide. In my role as the advocate member of SWOG's Clinical Trials Partnership under Dr. Kathy Albane's leadership, I provide feedback and recommendations that focus on the potential patient impact of trials being considered and developed. Next slide. I'm so excited to show this to you because we've been waiting a long time for plain language resources for patients and investigators. Some of you heard about this in the plenary. So here's an example of the plain language summary and social media toolkit currently under review by the CRB for S1800D. And here's my call of action to all of you. As you develop concepts, please be sure to represent the real world patient population that you treat. PS2 patients should be included whenever it's safe, and broaden your lab and pre-existing condition requirements to reflect the real world population as long as it's safe. That's the key phrase. Without real world participants, we're not going to be able to have real world trial results. Next slide. I'm so excited to continue working with all of you on our common goal to offer meaningful clinical trials to lung cancer patients that they want to, that they can participate in and complete and make a positive difference in their lives. Thanks to you all for all you do to help lung cancer patients. Thanks a lot.
All right. Lucy's going to come talk to us now about our lung committee, and she is our DEI champion. Thank you very much, Judy. This is a fantastic update.
Well, I'm just really going to introduce myself today. I'm new. I've been a nurse for, as I was telling Dr. O, for 50 years. But the last 15 years, I've worked in the in-core space with DEI. So I'm thrilled to be able to be a part of Lung Committee and introduce you to the efforts that we're going to be doing to try to increase representativeness of our trials. This was in all of your bags, if you want to advance slides. But we have 5 champions, and you've seen this in other meetings. You can go ahead. Just keep clicking. So the biggest thing I want to point out is all of that in red. That's a huge investment that Hope is doing to try to improve this. And I think with this kind of structure that's multi-layered and multifaceted, will have a huge difference. But I know that accruals are at the local level, and I'm willing to support any of your programs, any of your sites, either by coming in person or doing Zoom to work with coordinators or other groups, anything that I can do to help. Next. But we just have to really acknowledge that we can do better, that what we have been doing hasn't really changed the numbers, and so we have to work together to really find ways to dramatically take action that will change these numbers. Next. And thank you so much.
Thank you very much, Lucy. I don't know if you can hear me. Yeah. Thank you very much, Lucy. Okay, so next I will invite Dr. Wayne Hofstetter to come up and give us the thoracic subcommittee update. Hi. Either way, whatever makes you feel comfortable.
Hi, good morning. Wayne Hofstetter from Houston, Texas, MD Anderson. So just a few trials that we can go over that are going on from the standpoint of a surgical space. And I think you're going to hear about some of these other trials from, is Ray O here? Is Ray coming in? I don't recognize you. I haven't seen you in 2 years. It's nice to see you.
Who is he, right? Yeah.
You're not wearing a tie or a bow tie or anything. I don't recognize you.
Where's the bow tie?
Ray used to rock a bow tie. Now he's wearing a hoodie. Yeah, sweet. Nice to see you. All right, so some of the open trials, the Alchemist trial, I think, is at the point where it's almost got full accrual. Most of the studies have completed, other than the last one, to my knowledge. We are not running Alchemist at our unit, so if any of you have more knowledge than I have about Alchemist, feel free to chime in. My understanding is that we're still collecting tissues, and the last arm for the chemo pembro is still active, but that's all I know about. Any further updates that you all know about? Okay, I'm going to move on from there. NACIST, you're going to hear a little bit more from Ray later on. We've got final approval through the NIH and through the group, and so we need to start reaccruing and getting groups on board. How many different groups are open right now?
So we have 32 sites open, 38 in the pipeline, but we need more.
Right. And the reason that we need more is because this is a relatively rare subgroup of patients. If we don't want this trial to take 15 years, and we do not want this trial to take 15 years to accrue to, we need to open up as many sites as possible and definitely not squander any patient who's got a superior sulcus tumor away from this trial. So really try to focus in. Don't feel sheepish about you being the institution that enters 1 or 2 patients, because that's how this trial is going to be accrued to, and how we're going to complete it is that each individual site is going to be able to accrue maybe 1 or 2 patients to it. I recognize that this is a huge effort for all of you to go through to open the trial at your institution for a small number of patients, but this will bring about some meaningful change in this subgroup of patients, so if we can move forward on that. And you'll hear more about this from Ray. And then another study which we're collaborating with is through John Dosky and the Children's Oncology Group. They're looking at randomizing a group of patients who have osteosarcoma and looking at surgical options of open versus thoracoscopic management of pulmonary metastasis. This is open now for accrual, and if any of you are taking care of osteosarcoma, especially in a pediatric-based setting, this is a study that we should be pushing to open. You have to be a group that manages these procedures either thoracoscopically or open. So if you're a group that manages them completely open, at this point we need to be able to randomize between one or the other rather than selecting services or groups that do one or the other. The objectives are to find out whether there's an event-free survival based on differences in surgical approach. This is limited to patients who have less than 4 metastases. Certainly we wouldn't be considering a thoracoscopic approach for anyone who has more than 4. So this is for a relatively specialized subgroup of patients. Again, a trial that I think will take a while to accrue to, so one that if any of you have these patients within your institution, please think about opening this trial. And then finally, I think you're going to hear more about this from Gibney and his group, Dr. Rangel. This is in development. This is neoadjuvant and adjuvant immunotherapy for clinical stage 1A non-small cell lung cancer. Currently in the process of developing this trial, and hope to see some progress on this by the next time we're meeting in fall. Specifically, this group, a very, very small subgroup of patients, thin sliced yet again, looking at stage 1A patients, but further compounding on data that we've gotten in the most recent trial showing benefit to neoadjuvant immunotherapy in early stage patients. This is even in earlier stage patients. Again, we're looking at getting this open as soon as possible. I would hope that what we know from SWOG, maybe we can get this open within the next year, but we'll push hard. Questions? Okay, short and sweet. Thank you.
Great, perfect. All right. Perfect. All right. Thank you very much. So we will move on to the Thoracic Radiation Subcommittee update with Dr. Megan Daly.
Hi, everyone. I'm Megan Daly from UC Davis. I'm going to be giving the update for the Thoracic Radiation Subcommittee. And we, first of all, had a terrific meeting yesterday morning with lots of great new ideas and development. So we're always excited to get any new members, regardless of specialty, who want to come talk about local therapy trial ideas. I'm just going to use my 10 minutes to kind of run through very briefly the current radiation portfolio within the Lung Committee. We're going to be hearing about the active SWOG studies in more depth later, so I'm just going to very briefly touch on each of those and then make sure everybody's also aware of the good number of SWOG-endorsed studies that also involve radiation, each of which have a SWOG champion. But first, jumping into Maverick, which you'll be hearing about in greater detail from Dr. Chad Rusthoven a little bit later in the meeting. This is a very important trial looking at the role of prophylactic cranial irradiation in both limited and extensive stage small cell lung cancer. It's a trial with a very pragmatic design, allowing toxicity reduction techniques like hippocampal sparing and memantine, and it's obviously a population and type of trial that can be challenging to accrue to, so we'd really love as much participation as possible. And I think Chad is going to be talking in his section in more detail about the steps they've taken to try and make this as patient-friendly and investigator-friendly as possible. So we'd really encourage everybody, if possible, to open that. SWOG-NRG S1914 is a study that we're collaborating on with NRG. So Chuck Simone from NRG and I are jointly leading this study. And this is a trial in early stage medically inoperable non-small cell lung cancer, looking at the addition of atezolizumab. You see the schema here. We've also tried for a fairly pragmatic design with this trial, allowing a range of different radiation schedules. With a new amendment, it will allow schedules between 3 and 8 fractions. Also want to highlight that patients only require 6 months or 8 cycles of atezo in comparison to other trials in this space that do require a longer duration of immunotherapy. We currently have 90 patients accrued out of a target of 480, so we would really love to get any other sites that might be interested to look at opening this trial. Moving on to Dr. Ajmalali's trial, S1933. This is a very important trial in the poor performance patient space, looking at hypofractionated radiation and atezolizumab. Their accrual is moving along, but these are relatively rare patients. So you'll be hearing a bit more about this important trial shortly. Now, moving into the SWOG endorsed studies. The first one is an alliance trial that just recently activated. And Arya Amini is our SWOG champion for Alliance 08-2002. And this is a trial in advanced non-small cell lung cancer that is PD-L1 negative, looking at the addition of stereotactic radiation to immunotherapy-based treatment. So we think this should be a very interesting study that may be very appealing to patients. Next, moving into an ECOG trial, Dr. Matt Harkenreiter is our SWOG champion, and this is in the stage 3 unresectable patient population, looking at the addition of concurrent durvalumab to the standard Pacific regimen. So this is a fairly pragmatic and logical question, kind of the next step in stage 3. This is, sorry, I'm having a little bit of trouble reading the slides from here. This is LU005. If you want to enroll a patient to LU005, you need to hurry because this is completing accrual very, very soon. This has finished accrual almost 2 years ahead of schedule. And this, I believe Charles Hsu is our SWOG champion for LU005. This is looking at the addition of atezo to chemoradiation in limited stage small cell lung cancer. So you may have 1 to 2 months left to get a patient on this trial if you'd like to. Moving on to NRG LU002. Dan Gomez is our SWOG champion for LU002. This is a trial also in advanced non-small cell lung cancer, looking at the addition of consolidative stereotactic radiation to oligo-residual disease after frontline systemic therapy. They have surpassed the halfway point on their accrual, but still have a ways to go. It's currently on hold for an interim analysis, but should be reopening shortly. And then finally, NRG LU007, or the Raptor trial. Henry Park from Yale is our SWOG champion, and this is an important trial also in the extensive stage small cell lung cancer setting, looking at the addition of consolidative thoracic radiation in the modern immunotherapy era with the use of atezo. So also a very important and pragmatic question. We see the schema here. And then one last trial that will also be closing shortly, I hear. So if you'd like to put a patient on this trial, you also only have a month or two. And Dr. Lori Gaspar is our SWOG champion for CC003, looking at hippocampal avoidance for prophylactic cranial irradiation in small cell lung cancer. And that is it. Thank you.
Thank you. Perfect. Thank you very much, Dr. Daly. And so now we'll move on to our translational medicine subcommittee update with Dr. Phil Mack. And you can also put questions in the chat if you're joining us virtually, and at the end of this session, and or you can use the raise the hand function. Again, at the end of this subcommittee update section, we will get to all the questions.
Great, thank you. And welcome to the Translational Medicine Subcommittee section of the meeting. So on behalf of Fred Hirsch and Dr. Wistuba, who we'll be hearing from later on, I'll just present some very brief updates. First, in terms of TM manuscripts, we have multiple manuscripts that are in preparation or submission or publication. This includes the 1403 plasma kinetics, which I'll just remind you very briefly in a few slides. This is actually undergoing revisions right now, so hopefully it will be accepted very soon. We have additional manuscripts that are in preparation, working in concert with the Yale group, which I think will be very interesting. And this just sort of highlights the importance, I think, of making sure to embed appropriate correlative studies into your proposals, because we learn a lot more, actually, than we do just from the simple clinical findings from a lot of these TM-associated studies. 1507 correlatives have been completed, but lack of tumor tissue means that we're essentially going to be embedding them into the clinical paper. There were some significant findings, but nothing that was super dramatic. The 0819 has been published. And as has been mentioned several times already at this meeting, we have a number of manuscripts that are in preparation based on studies stemming from LungMap, and I'll talk about them briefly as well. So just as a reminder, the 1403 plasma kinetics, we have found that patients who drop to zero, completely clear their ctDNA at, in this case, cycle 3, so earlier on, have a dramatically improved response compared to those that don't. So here we're just looking at the change in the CTDNA kinetics. You can see that almost all patients go down, but those ones that are labeled red don't actually hit zero, and the ones that are blue do. And that translates into a very dramatic effect on how those patients actually perform. So here you can see sort of the tail end of that at progression, with the red ones, some of them progressing very rapidly. So in terms of progression-free survival, you can see here the extremely low hazard ratios, a very high p-value for this association. And we'll get into this very slightly as why this is important observation for how we can actually design clinical trials in the future. So very strong association with progression-free survival here. But this also translated into overall survival as well. So some of the findings here are that treatment-induced changes in ctDNA kinetics, again, early in the process, after 8 weeks in this case, we found that it was more predictive than RECIST in terms of predicting or anticipating durable progression-free survival. And it has been demonstrated in the literature to be an effective predictor of outcome for chemotherapy and for immunotherapy. Obviously, if you're doing it in immunotherapy, you can't track something simple like the EGFR driver. You need sort of this consensus approach. And then a lot of algorithms have been developed that will look at all of the ctDNA mutations, whether they're important to the cancer formation, whether they're drivers or whether they're just passengers, and make a consensus outline as to whether they're changing and how predictive that is. We also looked at that in this paper using a very prominent algorithm, and we found that actually just simply tracking EGFR was actually much more predictive. And the short answer to that is because of CHIP. But if you're doing something in a tumor type where you don't have a standard driver, which defines most of our IO studies, then a consensus approach is very appropriate. And so the reason I bring this up again is because for any of you who are considering developing clinical trials, this is an excellent way to effectively identify and manage innate resistance. which is really a critical element that we don't address very much. And you think, well, it should be pretty straightforward because these patients will not respond, they'll progress early in therapy. But this trial actually demonstrates that that's not always as clear-cut as you might think. A lot of these patients actually had initial responses. They just weren't durable responses. And we're able to tease those out by the plasma kinetics. So it may actually be 4 or 5 or 6 months before the patient progressed. But on an EGFR therapy, we're looking for a lot better than that. So this is an excellent opportunity to use this kind of kinetics in your trials that will allow us to augment therapies, not necessarily take them off, in this case, an EGFR inhibitor, but identify, maybe add in a MET inhibitor or other factors. And we have studies like that in development, but please bear this in mind for any studies that you're considering. Now, just going back to LungMap very briefly. LungMap has screened a lot of patients. Over 2,400 just in the most recent iteration of LungMap, so not even counting the 1,400. And that gives us a nice database, in many cases bigger than a lot of the ones that are actually out there, although tiny compared to companies like Foundation or Guardant that have really large ones. But we have a lot of patient annotation and data that goes with this, so it makes for a very nice opportunity to do sort of simple things, like understand the relationship between outcomes and co-mutations or tumor mutation burden or immune features or imaging or anything that you actually want to correlate here. It doesn't actually have to be a molecular finding, although those are of most interest to me. Just a couple things to bear in mind, though. For LungMap, it is not a representative cross-section of patients in the US, although it is a very real-world trial. It is biased by the types of sub-studies that are open, but also by the exclusion criteria in a lot of those studies. So there are populations that we see a lot of and populations that we don't see much of in terms of molecular demographics. And so in no way should LungMap be used as sort of a consensus for what's happening in the US in terms of frequencies of mutations. But it does allow us some pretty good insight into very specific classes of patients that are perhaps under-addressed in the clinic. And of course, no matter how many patients we have, when you start looking at subsets of subsets, the populations always kind of get small. Just to give 2 quick examples, and here this is something where Suki Pada and Katie Minichiello have been working on, along with David Cozano. And when I say leadership here, I mean people like me and Mary are very much involved in this, but Katie has been doing a lot of this analysis. So we have accumulated over 639 KRAS mutants, which is a lot if you think about it in context of starting to look at interesting subgroups. For instance, over 200 of those are from never smokers, which you can well imagine is a population of interest, as well as the standard things that we start to look at in KRAS, like P53 and STK11. We can look at other things as well. I became interested in these non-canonical KRAS mutations, such as, essentially they're in exon 4 mutations that show up all the time. They're weakly activating. We ended up not having a whole lot of those, but they were extremely interesting. They do not perform in the same way that a standard KRAS does, just to tease that out. So as I was talking before, this is not a good cross-section of patients in the US. Looking at our BRAF patients, is very underrepresented for class 1, your standard V600E, which is good in a sense. Those patients should be off receiving the appropriate therapies. Normally, the class 1s represent about 55% of the BRAF population in lung cancer. But we do see a number of class 2 and class 3s, as well as fusions and rearrangements and other events that make it a population of interest and a population that we should explore. And again, particularly without spoiling any details, the class 3 co-mutations are extremely interesting. So just on my final slide here, I think it's important now, in this era of oncology, that all of our trials of any agents, even things that have a lot of broad applicability and aren't necessarily really specific kinase inhibitors, should include studies that are based on identifying optimal patients of response, or maybe those who you predict will not respond. We need to get into these nuances so that we can actually refine our trials in ways to really maximize this type of information that we're getting now routinely on every patient. And this can be done by prospective statistically powered subgroups, or it can be done by upfront patient assignment, or if we're really not sure about it and it's just purely a hypothesis, we can build those things in. But I think right now, what we need to do, and what the TM committee is anxious to help you do, is really to build in studies that are integrated or integral, things that are actually statistically powered to look at some of these subgroups to test these important hypotheses about which patients are really going to benefit, which patients may need an additional therapy. And just as a final point, we're beyond the phase now where purely associative or correlative studies are going to be well respected or rewarded by granting agencies, pharma, or publications. It's great to come out and say that, like, we saw these associations, we saw these correlations. That's fine, but right now we really need to actually test these things mechanistically in the trials. And that means building in the TM components up front when the trial is in its development. And so with that point, I will thank you very much for your attention.
That was great. Thank you so very much, Phil. That was absolutely fantastic. And so now we will move on to Dr. Paul Hesketh, who I believe is joining us virtually.
Hi, Janelle.
Great,
can you
wonderful.
hear me?
Yes, we can hear you.
Great, great. Good morning,
Advance the
everybody.
slides. All right, I'll advance the slides for you. All right. Yes.
Great. Next
Okay.
slide, please.
Perfect.
So next slide. So I will give you a very brief update on our community engagement subcommittee. And again, I want to sort of add to the thank you that's been extended previously to Dr. Kelly, because really it was her vision that led to us establishing this group 4 years ago. And again, greatly and deeply appreciative of all the support that she's provided to me and to this group. So our charge really was to try to obtain better engagement by the community-based oncology members of the lung committee and really get them involved in all aspects of the clinical trial process, including providing input during the clinical trial development process, taking a look at the trial designs to see that they would meet community expectations, try to identify potential barriers that might block successful execution, really become champion for these trials in their community networks, and participate in monthly calls and in-person meetings at the group meetings, and really work in any efforts that are being done to try to enhance accrual. Next slide, please. So we have a small but very, very dedicated group of individuals that have been working, again, for the last 4 years. Next slide, please. And what we've tried to do is to extend the reach of our subcommittee by creating a larger group of community oncology support group, which are basically community oncologists that participate in our monthly calls. They serve as a real good sounding board to try to give us feedback about clinical trials. And we provide constant updates in terms of what the lung committee is doing so that they can, again, be very active advocates for the activities of the lung committee in their own institutions. Next slide, please. So one of the most exciting things that we've been involved with as a subcommittee has been partnering with the MedNet. The MedNet is a digital information platform directed toward physicians to try to share medical information. It's not simply limited to oncology, it encompasses other specialties as well. But this is a group that's been working very closely. Jeremy Kilburn, a member of our subcommittee, and then Nadine Husry is one of the co-founders of the MedNet. And more recently, Eliza Henry, who's at Loyola, is the medical director of oncology for the MedNet. and they've all been working together to try to use this platform to try to highlight ongoing lung trials. Next slide. So again, this is a digital platform where you can share information, and it really has a growing reach across the country with now over 13,000 oncology members, which include both radiation oncology and medical oncology, and really provides a forum by which these members can ask questions with really academic oncologists from multiple major medical centers across the country. Next slide, please. So we've tried to use this platform to basically highlight clinical trials that are very important to the Lung Committee. And we've started with 2 important phase 3 trials, the Maverick SWOG 1827 trial and SWOG 1914, and really use the MedNet to try to raise awareness. And with RAISE trial S1934 now active, we're also going to be developing questions and answers around that trial as well. So the outreach with Jeremy Kilburn's help has been to the NCORE sites, basically inviting SWOG members to join the MedNet via the NCORE PIs. They then get targeted newsletters highlighting questions and answers. And then these question and answers, the newsletters will allow a question and answer process to be done. The study PIs will be providing some of the answers. It also provides a mechanism by which we can poll the respondents about real world practice. And we have links to clinicaltrials.gov as well. Next slide, please. So this just shows the MedNet homepage. Hopefully this is somewhat familiar to many people in the audience today, and hopefully you're participating in it. But as you can see, basically we can highlight the fact that we have a SWOG trial by the SWOG emblem that sort of highlights that. In this case, it's the 1827, S1827 trial. Chad Rustoven is the PI, and essentially he's now responding in this MedNet homepage to question and answers that are being provided by the users. And again, it's really a mechanism to really highlight the trial, respond to real world questions about the trial, and really give it some much greater visibility. Next slide, please. So this gives you a sense of the overall program engagement with just these 2 SWOG trials. We've reached over 2,500 oncologists. We've had more than 9,000 views from those oncologists, and they've spent on average about 7 minutes interacting with these particular pages. Next slide. We've also more recently focused on another trial, the Insignia trial, which is a joint effort with ECOG Akron and SWOG. Ann Chang is the SWOG PI for this trial, S1709. And Ann has been able to answer questions on the MedNet relating to this trial. We've been able to poll participants in terms of what they perceive maybe some of the limitations of the trial may be, and hopefully try to uncover factors that are perhaps limiting enrollment. Enrollment has proceeded, but it's somewhat slower than what had been anticipated. And so this is a mechanism by which we may be able to get some real world input in terms of some of the issues that may exist. And as you can see, answers from Ann have been viewed more than 900 times over the last 12 weeks. And my last slide, next slide, just gives you a sense of what we're able to learn in some cases. This is a poll that we conducted relating to Insignia. And I think this is particularly focused on those individuals that have PD-L1 lower, less than 50%, trying to get a perception of what the preferred frontline treatment from the audience for the MedNet is in that setting. And as you can see, we have the results of a poll from 2 years ago, and then more recently, 2 years ago, the overwhelming number of providers would choose a platinum doublet with Pembro in that situation. And even 2 years later, the poll conducted in February this year, you can see that the overwhelming majority would still be choosing a platinum doublet with Pembro, which clearly could be a potential barrier to this trial which has 2 arms that start out with pembro alone as monotherapy. So again, just giving us a little bit of an insight in terms of what people are thinking right now out in the community, which may in fact indicate one of the limitations to accrual. So again, that's my last slide. I thank you for your interest, and anyone that's interested in this particular subcommittee, please feel free to reach out to me. Thank you.
Well, thank you very much. Thank you very much. That was an outstanding presentation, Dr. Heskes. If I can kick us off with just some few comments and questions, perhaps. I should probably take my mask off so they can hear me. So I'm thinking about, our faculty and our PIs in the room. What you have been able to do and reach, Dr. Heskes, with the approach and the partnership with MedNet. If there are PIs in the room who are interested in this approach for their trials, including the ones that are active and the ones that are in development, what would be your recommendation to them?
I would suggest that they basically reach out to me. Obviously, I think we're sort of rolling it out in a stepwise fashion. So it'll be very challenging to sort of do everything simultaneously. But I think the success that we've had so far, with the 2 trials that we've been focusing on, and we're going to be working on Ray's trial as well, there clearly are other opportunities. And I think we've kind of worked out the mechanism, and we're very, very grateful to the MedNet for their assistance. So what I would suggest is that PIs that are interested in potentially using this type of mechanism to get information out about their studies, please just reach out to me, and I'm happy to talk with them.
Okay, great. And the floor is open for questions. Dr. Osa and Dr. Hofstetter, we do have a question in the chat, so we'll just read that. Are there any opportunities for just-in-time enrollment for the Superior Sulcus trial?
This is Ray. I'm the PI for NASIS. Right now, no. We are currently asking that people go ahead and go through the CTEP registration process. Orphan disease, which is why just-in-time would be advisable. I'm definitely open to exploring that if there was a mechanism to do so.
So that's the challenge. We've talked with CTEP a lot about trying to have these types of things, especially for rare populations, and they just don't really have a good mechanism to do that. And so, but you should keep asking them.
Yes. No,
because
that's a great idea. We need it. Clearly.
The one thing I will say, though, is that this is such a morbid subset of non-small cell lung cancer. And even though it is relatively uncommon, when those patients roll into your clinic, you would wish you had something like this to offer them.
Yeah, all the more reason for the just-in-time, right? Yeah, exactly. It's a great point. And Dr. Chang, did you want to add to that, please?
Yeah, Paul, I wanted to thank you, first of all, for working with us around Insignia questions. I think even more than the polling, because the polling, keep in mind, is not SWOG institutions, so it's a broad community of medical oncologists who may not have the trial open or not. But I think this is useful information, but I think even more useful is the exchange that goes on online, back and forth around Insignia and understanding people's, and making a case for it as well. So I think that's really useful and important in community engagement. So thank you.
I really have a little bit, maybe it's a solution, because every time we try to get a patient enrolled to Insignia, one of the barriers would be the molecular profiling timing, because sometimes by the time they come and it takes extra time. So I was wondering if one of those molecular profiling companies or something, I think it's difficult to involve, but maybe it would be one of the volunteers or something to help expedite the PIs, especially in NCORP sites or so on, the molecular profiling results. because this is the major obstacle.
That's a great comment, Nagla, and I think that we've been, with all of the queries coming through, we've been very, it's, you know, if, for example, you have blood-based information available, that's okay in terms of moving forward. So, and we have an amendment that is actually going forward where we'll use some of this information. So it's very flexible, and that shouldn't be an area that prevents accrual. Thank you.
It's just the timing for, you know, for the results.
The turnaround time, yeah, very fair, very fair. All right, other questions? I think we're doing pretty good on time. Well, congratulations, and thank you again to all of our speakers this morning. I really appreciate you keeping on time and for all the work that you're doing. And really want to thank Dr. Hesketh, Lucy, and Judy for really helping us to highlight these important trials that we're doing throughout SWOG and the networks. And we look forward to continuing to work with all of you. Thank you. All right. And with that, we'll transition, okay, to our first scientific speaker, who I'll invite to the podium, please. All right. So this is Dr. McGarry Houghton. He is from the Seattle area. He is a pulmonologist in the Division of Pulmonary and Critical Care and Sleep Medicine at University of Washington School of Medicine. He is also a professor in Clinical Research Division and the Human Biology Division at the Fred Hutchinson Cancer Research Center. He studies lung diseases, especially lung cancer, and helps to develop new methods to detect and treat them. He leads the Hutch's Lung Cancer Research Group and has one of the few lung spores in all of the United States. So congratulations to him and his team. And he will be speaking to us today about targeting myeloid lineage cells to improve immune checkpoint blockade efficacy in non-small cell lung cancer. Yep, just slide it, yeah.
That's okay. I'll figure something out. So thanks for the invitation this morning. It's really great to be here, and the first time I've spoken in public in quite some time. So bear with me. Today I'll give you a story of sort of what we've been working on in my lab and how we're trying to get that to the clinic. And you know, I think everybody in this group knows this. I'm just going to give you my take on how immune checkpoint inhibitors work or don't work. There are really 5 major reports from the literature. It tells you, you know, what patients respond. These people smoke, they have a bunch of mutations. There's several studies that show if you have CD8 T cells actually in the malignant tumor, you'll respond. Interferon gamma signature is pretty well established. And then, of course, the PD-L1 high group. So the way I look at this is actually in series. So if a patient, you know they responded, and you go back and look at that patient, they probably smoked a lot of cigarettes. Because of that, they had a lot of mutations. In somebody who responds, you know you're going to see CD8 T cells in the tumor. Activated T cells gives the gamma signature, and then it's a little more confusing, but that constellation of events usually winds up in a high PD-L1 expressing tumor. You know, we all see the same patients, and at least for me, when you take out the targeted therapy type of patients, everybody, most fits the first 2. Most of the patients I see smoke a bunch of cigarettes and have a bunch of mutations, but very few of them fit numbers 3 and 4, and that's why our response rates are so low. So something is happening between number 2 and 3, and this is the type of picture that we've focused on in my group. So this is a squamous cell lung carcinoma, and in the middle there and to the lower right are 2 malignant islands of tumors, and in the upper right and lower left are 2 tertiary lymphoid structures or lymphoid aggregates. So what we know about these lymphoid aggregates is there is antigen presentation there. Theoretically, there should be tumor-reactive T cells, and they only have to go a very small distance there to get into that malignant island of tumor, but they don't do it frequently. And conveniently for me, all of those brown cells are CD66B positive neutrophils. And so we saw this pattern quite frequently and have decided to really look at your immune response and what are the drivers of the inability of lymphocytes to access malignant tumor. So we first started doing this 7, 8 years ago. Lung cancer resections just a few miles from here at the University of Washington did as much immune profiling as we could do with flow at that time. And we looked at about 51 immune cell populations, subpopulations. You can look at them, what's in the lung versus what's in the tumor. But the main question we had is what, if anything, anti-correlated with CD8 content? We ran every population that we tested, and the only one that we found were neutrophils in panel C there. So the tumor-associated neutrophils, when you have them, you don't have very many CD8s. And when you have CD8s, you don't have very many neutrophils. This was true in adeno and squamous. And again, none of the other populations fit this correlation. So although we saw this is, I would say, just fact at this point. So this is a separate study from Kwok Wong's group at NYU. In the blue bars, there are the CD8 T cells, and you can see that they're going high to low, right to left. And the green bars are the neutrophils, and they're going high to low, left to right. And that wasn't a major finding in this paper, but you can see that that is true. Other groups have seen a similar relationship. So that this sort of yin and yang between neutrophil and lymphocyte content, I think, is pretty well established. For people who don't follow neutrophils very much or pay attention to the literature on them, this highlights maybe their importance and outcomes. So this is the CyberSort group. This is some years old now, but they used gene expression signatures to infer immune cell content from 30 different types of cancer. And the worst thing you could have in terms of your survival were neutrophils. You can see in panel C way down there at the bottom, and most clearly illustrated in D. So that's breast cancer on the y-axis and lung cancer on the lung adenocarcinoma on the x-axis. So good is up and out. The best thing you can have for your survival are plasma cells, another thing that isn't studied enough. And then in the bottom left corner are the neutrophils. So again, by far the worst thing you can have in terms of predicting how long you're going to live is just having neutrophils in your cancer. So we went back to our cohort, we did everything we could do, and we tried to get a more clear picture on the immune response rather than just kind of looking at this simple relationship. So some statisticians in our group did unsupervised hierarchical clustering, and what came out of this is that there are these fundamental immune response subtypes. So basically there are only so many ways your immune system is going to respond to your cancer. We define these as inert, myeloid, active, and indeterminate. The active group has tons of CD8s and PD-1 positive CD8s. The myeloid group was rich in various myeloid populations, including macrophages and neutrophils. The inert group didn't have many CD45 positive cells, so there's not a lot going on in those at all. And the indeterminate group has that name because we haven't figured that one out yet, but we think it is an IL-17 dominant group. So the panel to the upper right is just to try and convince you that this actually is reality. This is a group just, a couple blocks from here, the Institute for Systems Biology in South Lake Union. They got over 10,000 TCGA tumors, did lots of profiling, not flow, but lots of sequencing and proteomic experiments, and they found 6 immune response subtypes. And these are basically the same thing. So they're interferon gamma dominant, the yellow one, C2, is our active. They're immunologically quiet, is our inert. And then the others are sort of combined phenotypes of the myeloid and indeterminate. And what's important to note about this is if you jump to immunohistochemistry, which I'm going to show you, and you find the cases that have CD8 T cells actually in the malignant tumor, the active group has that, but the other 3 don't. So effectively, these are 3 different subtypes of immune escape, and it's important to understand what's driving those mechanistically, because the treatment for those is going to be different. It's not, there's not going to be a one-size-fits-all. The gene expression signatures that we saw define the active and myeloid group are basically what other people would tell you. The active group is a gamma signature type of thing with CXCL9 and 10, and the the gene signatures that we saw for the myeloid group were actually neutrophil rich. CXCL5 is a neutrophil chemokine, and lipocalin-2 is a neutrophil granule protein. So this is one example of our multiplexed immunohistochemistry, and this pattern is really what led us to try and figure out what's driving the myeloid group. On the right is an active case. You can see that there is a lymphoid aggregate in the upper left. There are these cyan-colored CD8 T cells in that tumor. And trust me, that's used to be white cytokeratin-positive cancer, and it's just being infiltrated and eaten by these CD8 T cells. This is somebody that responded to immune checkpoint inhibitor. This is what you want to see. On the left is what you don't want to see. Again, there's lymphoid aggregate tissue. There are CD8 T cells in it, but they are not getting into the cancer. And in that particular case, those magenta-colored cells are neutrophils. This is the whole panel. Basically, we crafted it to be able to distinguish between the roles of neutrophils, monocytes, monocytic MDSCs, and macrophages, and try and figure out which one of those is really driving this myeloid group. It's important to note that lung cancer is very heterogeneous. So you can see that in A, that's a lung cancer resection. In B are 20 different region of interest boxes we put on. We looked at all those. And then C and D shows you how we analyze it. So panel E is one field, one region of interest, and that's the data for it. F is the 20 fields of that case. So you can see some of those fields are loaded with lymphocytes, CD8 cells, and some of them have very, very few. So depending where you're looking in these cancers, you can actually see different phenotypes in different parts of the cancer. And exactly how the dominant one plays out is not something anybody really has a handle on. So looking at a composite average, what we found is that the thing that's driving the myeloid cases are neutrophils. So whether you look in the stroma or the tumor or the combined metric of tumor stroma, the blue shows you that it's really the CD8s driving the active case. So there are more of them in the active cases than in the excluded or myeloid cases. The only thing that's flipped are the purple. So you can see that the neutrophils are higher in the excluded or myeloid cases in the stroma, tumor, and the combined metric, but none of the others that's true. Actually, monocytic MDSCs, which are notoriously immunosuppressive, go the other way. They're more prevalent in immune active cases. We just used a simple ratio of looking at the CD8 content in the malignant tumor versus the neutrophils, either in the stroma or tumor, and then just that simple ratio was able to distinguish between the two cases. So we moved into a cohort of patients at our center that were treated with PD-1 antibodies. This is just to remind you that now your resections are gone. You're not going to get those big things, and you're not going to do all this flow cytometry. If you do a single-cell digest of a core needle biopsy, you're going to get about 150,000 cells is what's in them. So we have turned to really gene expression studies and multiplexed immunohistochemical techniques to try and interrogate these responses. And what we saw that's really highlighted in D is when you look at the people who had CRs and PRs, they had more CD8 content than neutrophil content in the matched cases. But when you move to stable disease and progressive disease, those ratios now are quite flipped. And you see lots of neutrophils and very few lymphocytes. Again, you can make a simple ratio of those that separates the cases, the responders and the non-responders. And I think that the PFS curves are important because if you just look at CD8 T cells in and of themselves, they don't separate good and bad. Neutrophils don't separate good and bad. But when you put that in a combined metric, you can see the low ratios really drop out. None of those people really got to cycle 2 or 3, whereas the other group did quite well. So the summary to this point is that we think that there are only so many fundamental immune response subtypes. I'm not going to say it's only 4, but it's limited number. I don't think it's any surprise to you that CD8 T cells seem to be driving the active phenotype. And we've concluded now that neutrophils are really the driver of the myeloid subtype, not every single case in it, but as a group. We are interested in looking at these ratios in the future. We were able to show here that they predicted PD-1 treatment failure. We validated that. I didn't show you an independent cohort. So what I'm going to show you now is our plans going forward clinically. So the easiest way today to antagonize neutrophil function in a cancer would be to use a CXCR1 or 2 antagonist. CXCR1 and 2 are the chemokine receptors. It's a little bit confusing in that everybody just thinks if you block the chemokine receptor, they won't go into the cancer. It's not that simple. These receptors mediate activation and motion. So there's a two-edged sword there. This is a mouse model of squamous cell carcinoma, P10LKB1 mice. And when we treated them with SX682, which is a dual antagonist for CXCR1 and 2, and with PD-1 antibodies, you can see that PD-1 didn't do much to the green cells. Those are the neutrophils. But when you add the SX682, you see that the green kind of starts going away. They locate more to the periphery. And some of these yellow CD8 T cells come in. So the blow up on 40X, you can see there's a fair amount of CD8s, and there are these black holes in there. Those are not alveoli. Those used to be clusters of, these cancers kind of grow in a cluster of grapes, and those are just drop out of tumor cells. So this is the closest we've been able to show there's actually tumor cell killing here. But what we have focused on, mouse models are not great for studying these immune-based drugs, but there are surrogates that can show you you're doing what you want. And we think that the gamma signature is one of those things. So just giving CXCR1/2 antagonist, you can restore the interferon gamma signature, which means you've got more T cells and more activated T cells driving these pro-lymphocytic chemokine axes. And we think that is really the fundamental thing that neutrophils are prohibiting. So what are we going to do now? We are going to do a trial with this particular CXCR1/2 antagonist from a company called Centrix. It has been used in one clinical study thus far on the East Coast in melanoma. They have had a few treatment responses in people who'd failed Ipi/Nivo, so there appears to be some activity with this. The recommended phase 2 dose has been established. The downside to this that actually is the upside is that people get neutropenia with this, but that might actually be the desired effect. So they are driving the ANC numbers pretty low in that trial. So I am a pulmonologist. I don't do clinical trials or treat patients, so I'm fortunate to have Chris Bake as my partner in this, who's in the audience, and Mary Redmond, who designed the trial statistics also at our center. We're going to do this in the first line and combine this with Pembro for the PD-L1 high group. Remember, the PD-L1 high group is great, but there's still only about 40% respond, right? So there isn't a lot of options for those patients, so we thought that might be a population would be interested. And then we'll also look at this in the PD-L1 low group. Phil Mack, made it very clear that we need to do correlatives and embed them in the trial, and they will be. So mandatory pre-treatment biopsy, we will try to get on-treatment biopsies. I think there's really a dearth of these 6 to 8 week, that's the moving action. And if we could get those biopsies, I think we could understand what is and isn't happening here. The primary outcome and the secondary outcome are listed. So the things that we're going to do with this is basically what I've showed you, lots of multiplexed immunohistochemistry. We have narrowed down, we have RNA sequencing on all those cases. I didn't show you that, but we're narrowing down the actual gene signatures we'll look at to a handmade nanostring panel. And we'll test the ratio that I showed you of CD8 T cells and neutrophils in the tissue, and obviously the gamma signature. Many of you probably have heard about the neutrophil to lymphocyte ratio. This is just looking at somebody's CBC and calculating that. That correlates in a pre-immunotherapy era with overall survival and a number of metrics, and it's been shown to predict response to immune checkpoints in many diseases, melanoma, non-small cell lung cancer. And we'll look at the plasma IL-8 split point. So this is work that came from the Yale group in lung, basically that high IL-8, the dominant chemokine for neutrophils, is usually a bad thing and predicts failure. To immune checkpoint inhibitors, we think that actually we will be able to effectively treat some of those patients in that subgroup that otherwise don't respond. And then just kind of my parting shot, one thing that we're adding in that is new to us, the idea is you have T cells that release gamma, and there are cells that take that gamma and make this interferon gamma signature, which brings in more T cells, more gamma, and you get this positive feedback loop. Now, most of us thought that the cell that was an important player in that feedback loop was the macrophage, that they were seeing the gamma, making the CXCL9 and 10, bringing in more lymphocytes. This is, you can't stain for things like CXCL9. It just, you can't do it. So this is FISH. So this is in situ hybridization using these new RNA probes. And so this is a combined FISH MIHC approach. The red is CXCL9 RNA transcript, and then the others are protein markers. You can see in those images that those red cells are cancer cells. And this has been identified from some other groups now. So why a cancer cell would make this thing that's going to bring in cells that can kill it is confusing, but it does happen. And you can see in this particular case that the CXCR3 positive lymphocytes are starting to get pretty close to those red tumor cells. We're trying again to understand how do neutrophils, we think, just abolish this whole process and this whole feedback loop. And so we're going to include these types of new studies going forward. And this just shows you the kind of fancy stuff you can do. All of those red cells are on the edge of the cancer. None of the cancer cells in the middle of the cancer are making that. So they didn't just up and decide to do this. They're responding to something in the tumor microenvironment. Obviously it's interferon gamma to do this. So it's really at that leading edge where the action is, and that's where we're going to focus our studies. So I'd just like to recognize the people doing this work. Xiaodong Zhu is a really talented staff scientist in my group who does all of the multiplexed immunohistochemical studies. And I've highlighted Chris Bake. I should also have highlighted Mary Redmond, who are really going to do this clinical trial. I'm just going to play with the correlatives. So thank you for your attention, and I'd be happy to answer questions.
Outstanding. Thank you very much again for coming to speak with us. I'll kick us off. There's some questions in the chat, and thank you, Dr. Redmond, for helping to field some of those. We appreciate that. I'm going to ask you to stay up here to answer questions. I can't answer them. I appreciate your confidence in this panel. We're good, but we're not that good. All right. So it's fantastic. I mean, I think this is what we want to see. We want to see from that bench to bedside, right, and then bedside back to bench. And when we think about translating this and learning from the trial that you've developed, I'm wondering, I see that you have the optional on-treatment biopsies. If you could talk to us, and Mary, maybe Dr. Redmond may be a good person to answer this also. One of the things we struggle with a little bit as investigators is we like to get those on-treatment biopsies, but when you have a combination approach, so everybody's getting Pembro plus this medication, how do you distinguish about what's driving those on-treatment effects that biological changes that you're seeing in the biopsies, and what's kind of your thoughts and your approach on that? I know it's something we all struggle with, and I thought maybe you could shed some light on that.
Well, and these are complicated conversations. First off, I think going for the second line where somebody has failed, then theoretically maybe they're stayed on Pembro and you added something. So in that case, you think your drug is what's different and that driving the response. In the first line, we lost that. I think that there are a number of reasons why we did it this way. Number one, the second line approach has failed. Almost everybody has failed, and many pharmaceutical companies are not even interested in tackling those trials anymore. So I'm not saying that we shouldn't do it, but this was really the only feasible way to do this particular study. Then I think you've got to go to the correlatives. I mean, you have to be able to see the signals you want to explain what's happening. But it's a challenge. Yeah.
Very fair. Very fair. Thank you very much. All right. We have somebody at the microphone. So we'll start at the microphone, please, and then we'll go to the question. There's an additional question on the chat, just so you know. Good.
Thank you. It's Young Che from Northwestern. It was a great presentation. I really enjoyed it. My group's been looking at the NLR from the blood and how that could be a strong predictor, and multiple studies have supported the finding. And we also looked at the delta, how that NLR changed over time with therapies, and that seemed to correlate with response to therapy as well. So, I think, you guys can look at the correlation and look at the dynamics of the change in CBC, as well as if you get enough on treatment biopsies, how that ratio changes over time, how that can correlate with better response, and more closely with probably durability of response. And then also, we've looked at some of the B-cell markers, activated memory and all that. And the TCGA correlation studies from my group have shown that there seems to be inverse relationship with the activated CD8 T cell as well. I know Lisa Cousins and many have looked at the B cell biology with regulatory B cell, and there's a lot of complexity in that. But do you have any thoughts on how B cell can play a role in interacting with the myeloid and everything else?
Yeah, so I didn't show this data, but when we did the original flow, we collected non-adjacent lung tissue from all these patients at least 3 centimeters away. So that was what we used as sort of what your normal immune response in your lung would be. So in normal lung tissue, B cells account for about 0.5% of CD45 cells. But in lung cancer, they account for about 4%. So that's 8 times. Now, there are cells more prevalent than 4%, but that was the biggest delta we saw by far. I mean, nothing did that. So there is this huge increase in the number of B cells, and when you look at the tissue, it's easy to find them. They're mostly located in these aggregates, but not entirely. How they are working in immune checkpoint inhibitors is just something that it has been a challenge for us. I don't have expertise in B cell biology. We are looking at aggregates and the role of them more closely in B cells. There was a good paper in Nature Communications from a Pittsburgh group just a few months ago in head and neck that showed that those B cell content actually correlated with good outcomes in head and neck squamous. So I think we need more studies like that. There are very few of them.
Thank you.
Perfect. All right, great. And I think I think these are similar questions. One is telling you congratulations on the very beautiful data. And the question here is there a correlation between the peripheral blood neutrophilia and the NLR ratio, which is usually a poor prognostic factor, and then the neutrophil infiltration in the tumor? So it's really that blood to tumor correlation.
Yeah, so, in that particular cohort I showed you, I didn't show you the NLR data because it didn't really look very good.
Okay.
We also had a small cohort, and a few of those patients didn't have differentials available, and so we couldn't really make a statement on that. When we look at blood and we look at lung tissue, which is pretty close, and then we look at the tumor, and then of course flow is just giving you a chunk of tumor, you don't know where it is, and then you've got this immunohistochemistry where you can see where these are. It's my own bias that looking what's happening in the tumor microenvironment is vastly more important than looking at what's happening in the blood. And so that's why we're so adamant in doing the biopsies. I think once you really understand what is driving changes in the tumor microenvironment, then you can look for those signals in the blood, right, that are more easily accessible. But I don't know that we need to know if the NLR really tracks with what's happening in the TME, and no one has really put that together yet. We haven't been able to do that.
Right, but perhaps you can be the first to highlight that for us, then it sounds like
We're
a
working
great
on it.
trial. All right, well, congratulations again, and thanks
Thank you.
again. Wonderful. All right, we're doing very well on time, so thank you again to all of our speakers. We are going to take a 5-minute bio break, 5 minutes, and we'll be right back. Good idea.
See, you can tell the
No, it's like, man, let me drink my caffeine.
It starts out slow. Go ahead and go. Pretty soon the melody is like a rainstorm tin roof symphony. But it starts out slow. It goes on and on.
All right, we're going to get restarted. I actually gave you 6 minutes. All right. We're going to have Dr. Gandera kick us off with some of the updates on the active studies and kick us off with some updates on LungMap as a whole, and then we'll go from there. Thank you. All right, why don't we go to...
Okay, well, thank you. I'm subbing for Roy Herbst, our PI of LungMap. He's at AACR right now. And this will be very brief. Some of you saw these, I think, 3 slides yesterday during our LungMap update. But you're already going to hear and have heard about many of the recently completed studies, the developing studies. So I was asked yesterday to focus on our accomplishments. And so I wanted to show you when we developed this concept for a master protocol, which we didn't do in a vacuum. It was done jointly with the NCI, with the FDA, with the Friends of Cancer Research, patient advocacy group, with all the groups and a number of pharmaceutical companies as well. These were our goals. So this is 2014. We wanted to test anti-cancer therapies in a way that then could not be done by industry because it was in these rare and uncommon genotypes where now, they're just increasing almost every few months in terms of a new oncogene where we have a targeted therapy. And we've been able to successfully do that. In fact, we've completed 9 trials just in that space. We also wanted to test anti-cancer therapies in groups of patients that had failed immunotherapy. And we've completed 4 trials in the immunotherapy component, 2 specifically in this space, one of which you'll hear about at ASCO we think is very exciting because this is a big unmet need. The third was to take what was then a research tool, and I know this sounds maybe odd to some of you, but in 2014, next-generation sequencing wasn't being done. It was less than 2% of patients with advanced stage non-small cell lung cancer. It was considered research, although some tests, such as the Foundation test, who we partnered with, was commercially available. We wanted to be able to take that not only into our academic centers, because most people weren't doing next-generation sequencing then, even in academics, but also into community centers, and we did that. We wanted to be able to do it with a turnaround time that was applicable to clinical care, because even at that time, most of these were done retrospectively, it was research, and the turnaround times, even for Foundation then, were typically a month or more. And so over all the patients that have gone into the LungMap studies, our average turnaround time is 9 days. So we've been able to do something that really could apply it to the clinic. We wanted to expedite the clinical trials process because this is a public-private partnership. It's different from anything the NCI has ever done. And of course, that's been very successful. And you've heard this theme before about broadening the availability of state-of-the-art clinical trials to the community. So no one has 900 sites like LungMap does, all CIRB approved. No industry can compete with that. Roy likes to call this a giant funnel of we're screening all of these patients to be able to put them in various categories for sub-studies. So again, bringing the trials to the patient rather than sending the patient to a few academic centers. And then lastly, we wanted to use this resource, which we've created over 10,000 samples, to create new science. So this is the famous LungMap dot map, which shows all the sites. It's supposed to be 900 plus, and it grows all the time. Only maybe a year ago, it was 750. And I won't read all the accomplishments. there. But you can see we've really done, I think, more than was anticipated under very difficult circumstances. Within 8 months of launching LungMap, the entire therapeutic landscape changed when nivolumab was approved in the second-line setting in the very space we were in. So we've had to pivot multiple times. This is the current schema. Again, you've all seen it. I won't belabor it. Excuse me. But to say that we have probably, and you don't see it on this slide, the largest number of developing trials that we have ever had at the same time. So the drug selection committee is very active. We have so much interest now from a whole variety of pharmaceutical partners to join us. And then lastly, this is just a snapshot of creating new science, and it just shows several areas where we have presented some of these now fully published new science that has been created out of the LungMap platform. And again, I won't belabor these because I know we're short on time, but I'll be happy to take any questions. I don't presume there will be any questions.
We'll hold them till the end, perhaps?
Okay,
Is that
great.
good? Thank you so very much, David. Fantastic update. And really, congratulations again and kudos to the entire LungMap team. You know, I mentioned in one of the meetings yesterday, I still remember sitting in one of the rooms here and just listening to David and Valley make that pitch about this, and to see that evolution and where it's gone now is unbelievable. So kudos. All right, we're going to go back to Dr. Ray Osa's study and have him present. I think as mentioned earlier today, you would get more of an update going into a little bit deeper on these trials.
Great, thank you. Thanks, everyone. So we're excited. This trial, as you recall, is the new generation superior sulcus trial. Why superior sulcus? Relatively orphan non-small cell lung cancer. Very, very morbid because of the high risk of brachial plexopathy, so patients are in excruciating pain. It's a relatively poor outcome, a subset of lung cancer. Even though typically regarded as curable, our achievement of that tends to be, difficult. And the standard of care was established through an intergroup trial that was driven through SWOG, INT0160, almost 2 decades ago. So we're really excited. That standard of care was the epitome of multidisciplinary care because it was trimodality: chemotherapy, radiation given concurrently with surgical resection, and then there was post-resection chemotherapy that was given. It was a single-arm phase 2 trial, but it absolutely transformed the standard of care. 110 patients, the complete resection rates were higher than anything anybody had ever seen. There was a path CR rate that turned out to be highly predictive of outcomes. And the overall survival was better than any historical reports. Now, that was 20 years ago. Each of the components of that trimodality treatment has changed. Surgical resection has improved quite a bit. The radiation doses that we now use are very different than what the 4,500 grays that were used in that clinical trial. And of course, the chemotherapy components have changed. And we know we are in the world of immunotherapy. So there's this opportunity to do a study that, although in a relatively orphan disease, would give you a contemporaneous control group. So we couldn't do a single-arm trial as was done 2 decades ago. We had to have a contemporaneous control group. So you see here our schema. You have the experimental arm, which gets the same standard dealer's choice chemotherapy selection with modern doses of radiation therapy. and then also atezolizumab, the surgical resection, and then a year of atezolizumab. And our second arm gets standard of care, chemotherapy, radiation therapy, on to surgery. Primary objective is a PathCR. Why is that? Because PathCR is the only thing that was linked in INT 0160 to a survival benefit. So that's our primary endpoint. We have a number of secondary endpoints. If survival endpoints are there, surgical resection rates, complete surgical resection rates, toxicity, patient-reported outcomes. We're also going to be looking at other exploratory outcomes, including we will be collecting blood and tissue for correlative studies. We're very interested in a radiomics study to try to understand how to better predict responses. One of the main failures of the previous trial was that CT technology was a spectacularly ambivalent way of predicting what was going to be found. It was a two-way miss. Radiologic responses you found didn't translate into pathologic response, and absence of radiologic response actually you found patients had done very well. So the selection criteria are straightforward. Superior sulcus, which is clearly defined. These are T3, T4 tumors by definition, N0, N1s, and patients have to be able to tolerate each of the 4 treatments that potentially could be involved. And that is my, so orphan disease, okay, it's strange to call a lung cancer orphan, but it's about 1% of all we see. We have 32 sites open, 38 about to open, and I want to implore everyone to support this. The last trial we did was 20 years ago. The next trial we're going to do is not going to be 20 years. It's going to be maybe even longer, because this is, thankfully, less and less common than it once was. So let us do the best clinical trial that we can, so we can glean everything we can out of this. Thank you.
Fantastic. All right. Thank you very much. Okay, so we'll move on to our next presentation. So Dr. Rangel, are you joining us virtually?
Dr. Ray, actually, Dr. Rangel isn't here, so I'll be presenting.
Okay, perfect. All right, you can just say next and we'll go from there.
Sure. So I'm going to be presenting LungMap S1800D, which is N803 and IL-15 superagonist in combination with pembrolizumab for lung cancer. And this is on behalf of Dr. Rangel and myself, study chairs. Next slide. So this is a slide which depicts the schema and some of the prior work that's been done in this space. IL-15 is a cytokine superagonist that has the properties similar to IL-2 by expanding NK cells in CD8 positive T cells while sparing CD4 regulatory cells. And in the process may have mitigated toxicity compared to IL-2 in the traditional IL-2. So here was a study that Dr. Rangel had done, published in Lancet Oncology, looking at the compound ALT-803, which has subsequently been known as N803, in combination with nivolumab, and it was a phase 1b study. And in this study, they accrued patients, established a recommended phase 2 dose. They looked at immunotherapy naive patients as well as PD-1 progressing patients. And on the heels of this study, the current LungMap S1800D has been initiated and proposed. Next slide.
That's it.
Okay. So just to round out, the study will have 2 different cohorts, acquired resistance cohort which is a total of 334 total patients, a primary resistance cohort, which is 144 patients. The study is actively accruing. In fact, we have 4 accrued patients so far. And Dr. Rangel and myself are available for any questions about eligibility accrual. We're very excited about being able to move this study forward. The N803 is injected subcutaneously every 3 weeks, the pembrolizumab IV every 3 weeks. And the primary objective is to compare the overall survival across the combination of N803 plus pembrolizumab versus standard of care chemo. The chemo that is used in this study is at the investigator's discretion, and that's docetaxel plus ramucirumab, docetaxel, gemcitabine, or pemetrexed. So really excited about moving this forward and the current patients who are accrued.
Great, wonderful. Thank you very much for that update. We wanted to really take a moment to highlight these 2 trials in particular because they're the ones that have recently opened, and we'll again have open the floor to questions at the end of this section. All right, thank you again. All right, so we'll go to Dr. Pata, who's going to be giving us an update on S1900E.
Good morning, everybody. Thanks, Dr. Gray. I'll be presenting on behalf of myself and also Dr. Gerber at UT Southwestern, who's the co-chair for this study. Next slide, please. Next slide. So this is the S1900E schema. I think many of us are familiar with this, but this is the purpose of this study is to examine the activity of sotorasib in co-mutation subsets of KRAS G12C mutated lung cancer. So this sub-study is focusing on patients specifically with non-squamous non-small cell lung cancer who have received at least 1 prior systemic therapy. Could have been immunotherapy, could have been chemotherapy, could have been a combination. The patients cannot have uncontrolled brain mets. And then very importantly, as part of S1900E, there's a very rigorous upfront biomarker definition and classification for patients to be assigned to these different cohorts. And the specific biomarkers that are being looked at are, of course, KRAS G12C, but also co-mutations P53, STK11, and also KEAP1 axis mutations, including NFE2L2 and CUL3. And in order to be assigned to the P53 mutation cohort, it has to be an exclusive co-mutation in P53, so wild type and the other biomarkers I've just mentioned. Similarly true for the STK11 mutation cohort, but because we wanted to be inclusive to allow patients to enroll in this study, there is another cohort for those who may not meet those specific biomarker definitions. Patients are treated with standard dosing of sotorasib at 960 milligrams daily. Pretty easy follow-up in terms of frequency, clinic and visit and labs every 3 weeks, imaging every 6 weeks. And then importantly, at the time of progression, a liquid biopsy will be collected. So not only can we determine the resistance mechanisms across all of these cohorts, but also notice if there are any observations and differences of resistance mechanisms depending on the co-mutation present. The primary endpoint of this study is objective response rate. Next slide, please. So this is the current update. In terms of accrual, we have 58 of 105 patients enrolled. Just as a reminder, it's about 1 year now since this study has been open, and we are either targeting or ahead of our accrual timelines, which is of course very exciting. So 24 out of 40 in the P53 co-mutation cohort, 13 out of 25 in the STK11 co-mutation cohort, and then 21 out of 40 in all of the others. And even in the last 30 days, there's been 6 enrollments, which is very exciting. So we acknowledged, of course, we all know that sotorasib was approved in May of 2021, but we believe this study to remain important. And the reason is because the sample size, we're going to add 105 patients to code break 100's 126 patients. Again, the major advantage of the study is a rigorous upfront co-mutation testing and the prospective nature, which allows our confidence around the objective response rates to be narrower. So hopefully that 95% confidence interval gives us more confidence in how we may think about activity of sotorasib in these different co-mutation subsets. And as we heard from Dr. Gandera, given the lung map's reach with 900 sites, we're also hoping to enroll in more diverse population. So we acknowledge the approval. We wanted to make this as easy for investigators and patients to enroll. So an amendment just has been approved that I'd like you to be aware of, which essentially the theme is liberalization of eligibility. So this also includes now patients with untreated asymptomatic brain mets can now enroll in S1900E. Per the recent NCI guidance, there are shorter washouts for prior anti-cancer systemic treatments and radiation. We had initially a lot of questions about drug-drug interactions. We've provided clarification with this new eligibility. And then very importantly, we didn't want to have to stop to do an interim analysis in light of the approval. So the interim analysis that was initially planned has also been removed. So I think things overall are going very well. And I think all the investigators' support of S1900E and of course the patients as well in participating in this important biomarker study. Thank you.
Great, thank you very much. And we'll take all the questions again at the end. All right, so. So S1900F, this is kind of a refresh of S1900B. While S1900B was running, selpercatinib was FDA approved, and so we've worked with the lung map team as well as with other committees to ensure that we can evolve the trial to be relevant in the present day. And so where we have landed with this study is in those patients who have received prior RET inhibitor therapy. When they progress, we really don't have definitive therapy at what we should do subsequently. And in this setting, we designed this study where the patients will receive platinum-based doublet chemotherapy with carboplatin and pemetrexed, plus or minus the selpercatinib. Now, they could have received any RET inhibitor prior to this. They could not have received chemotherapy in the stage 4 setting, but may have received chemotherapy in earlier stage disease as long as there was no evidence of progression on that chemotherapy within a year. The primary endpoint for this study is investigator-assessed progression-free survival, and we're looking to seek a signal here and are enrolling 66 patients. Similar to what you heard with Dr. Pata, there's also ctDNA, liquid biopsies, built into this study so we can look at the resistant mechanisms of that RET inhibitor that was given in the earlier line, as well as looking at signals from progression from these from this therapeutic options listed here. So we look forward to opening this trial shortly. I think we have for the timeline update from this study, we have been reviewed by CIRB as this week and received no inquiries to date. We will get the formal feedback from them next week and look forward to working with the lung map team to get this open as soon as June is our understanding. We'll take questions at the end. All right, so, and we'll go to Dr. Chad Rustavan. Dr. Crean, you're on deck, just so you know. Oh, you're up next, yeah.
Thank you, Dr. Gray. So I'll be giving an update on the MAVERICK trial, SWOG S1827, and this is a trial of MRI brain surveillance alone versus MRI surveillance and prophylactic cranial irradiation, a randomized phase 3 trial in small cell lung cancer. Next. Oh, great. So I know people are familiar with this trial, but briefly, here's the schema. So the MAVERICK trial includes patients with small cell lung cancer Importantly, both limited and extensive stage lung cancer patients are eligible. Standard criteria for considering PCI is involved, so no prior brain metastases and no brain metastases after completion of first-line therapy. And then the randomization is a straightforward one-to-one randomization. All patients will undergo brain MRI surveillance, and one arm will receive prophylactic cranial radiation, and the other does not. Patients are stratified by limited versus extensive stage, immunotherapy, and performance status. The brain MRI surveillance schedule is consistent with the standard of care every 3 months during year 1 and every 6 months during year 2. And the primary endpoint of the trial is overall survival with a non-inferiority hypothesis. So our hypothesis is that in the context of close MRI surveillance, that any excess brain metastases that might occur without PCI can be identified and offered effective salvage therapy, and therefore there would be no difference in overall survival between the arms. And so I had some, just a few notes on this trial. So this is the first trial, to our knowledge, that's ever been done looking at MRI surveillance plus or minus PCI in limited stage disease. So this question has been looked at once in extensive stage disease in Japan, and that trial showed no differences in overall survival in extensive stage disease in a Japanese population. And so now there's conflicting data from an EORTC trial in extensive stage disease and the Japanese trial. But this is the first time this has ever been looked at in limited stage disease. And so this is a very important trial because if you look at the NCCN guidelines, you'll note that PCI is still considered the standard of care, and this is really trying to reassess that question with the availability of MRI surveillance and more effective salvage therapies. And then it's also very important to help resolve the conflicting data on PCI in extensive stage disease. People have strong feelings about PCI in that setting, but PCI is still commonly delivered across the country and in other countries for extensive stage as well. And so we're really hoping that this will be the definitive trial on that question. A few things to note about just the pragmatic design of this trial. Any and all first-line therapy approaches for small cell are acceptable. So we really are trying to limit the barriers to accrual. We also allow hippocampal avoidant PCI, so there's a lot of interest in that as a cognitive preservation strategy, and that's built into the study. We have a very wide eligibility time window, so patients can enroll in this trial up to 16 weeks after completing chemotherapy to try to make it as flexible as possible, especially for people coming from far away. We also have a baseline posture of trying to allow dual enrollments and accommodate dual trial enrollments wherever possible. So we never want a patient's interest in clinical trials to be a barrier to accrual on this study. And we're always willing to work with people to find a way to try to make that work out. In terms of accruals, the trial has currently accrued 88 patients. Which, depending on the hat you wear, is pretty good for a difficult randomization like this, but it's also below our target goals, where the study design currently calls for 600 analyzable patients. And so we are in the process with Mary Redman and our statistical team of looking at potential statistical modifications that would allow us to reduce the accrual goal to something that we would meet in the 5-year window of accrual, which would be about 250 patients at the current pace. So that's something that's in process, and we'll certainly keep the lung committee updated with our progress on that. And then there are some welcome opportunities for accrual that are forthcoming with the closure of some important NRG trials. So you may be familiar with the NRG LU005 trial. That's a limited stage trial that is looking at chemoradiation plus or minus concurrent and adjuvant atezolizumab. And that trial, as was mentioned earlier, has accrued extremely well several years before its target dates to complete accrual of 500 total patients. And I think that it's on pace to be completed in the next couple of months. So that trial didn't allow dual enrollment onto Maverick. So as that trial comes to a close, I know many sites have both the LU05 and the Maverick study open. My site has both open. We think LU05 was a great study. But that should actually give us an opportunity to have more patients eligible for Maverick. So if you have both of those studies open, please be aware that LU05 is going to complete accrual soon, and hopefully it'll allow more patients to be offered this trial. And then another competing trial that was also a great study, NRG CC003. That's a study where all patients with small cell get PCI and are randomized to hippocampal avoidance versus not. And that trial has almost completed accrual of its target of 392 patients. I think they're about 10 patients away. So that trial should complete accrual in the next few months as well. That's a study that's championed by the lung group here, so I know that some sites have that open. And I would encourage you to please consider opening the Maverick trial if you had CC003 open. Maverick could be reasonably considered a good successor trial to CC003. CC003 is trying to establish hippocampal avoidance, and hippocampal avoidance is allowed on the Maverick trial and may be kind of the preferred way of doing prophylactic cranial radiation going forward. So those are my updates, and I also just want to say thank you so much for supporting this trial and for offering it to your patients. I think it's a really important question that has implications not only for survival, but also quality of life for this patient population, and I appreciate your support. Thanks.
Thank you very much. Great, fantastic update, and we'll have Dr. Karim next to give an update on her small cell study as well.
So I'll give an update on our study of S1929, the phase 2 study of maintenance atezolizumab, the standard of care, versus atezo in combination with telazopirib in patients with SLFN11 positive extensive stage small cell lung cancer. Next, please. Do I do it? Oh, sorry. Okay. So basically, our patients, or patients would be screened after the first cycle of platinum etoposide plus or minus atezolizumab. At the time of the screening, patients are allowed to receive up to 2 cycles of combination platinum etoposide plus atezolizumab, if that's the condition, or up to 4 cycles in total. And they will be basically randomized to either arm A of atezo, the standard of care, versus atezo plus telazopirib. However, PCI and consolidation thoracic radiation are also allowed prior to step 2 randomization. The primary objectives are the progression-free survival. Secondary objectives are overall survival, response rate, and adverse events. TM basically are to bank the specimens for future correlative studies. So most important, okay, well, there's one slide in the middle, but I just wanted to add that including the eligibility criteria, we add now the FNA. So FNA is allowed in addition to the biopsy, in addition to the other eligibility criteria. So the study has been activated in June 2020 for the screening goal of 323 patients. We did screen to date 215 patients. Of those, 205 were evaluable for the SLFN11 results. Of those, 133 were SLFN11 positive. 63 patients were randomized already to receive the treatment, and those 63 are out of the 84 or 94 target. The SLFN11 testing time, median, was 6 days, and the specimen and results received within 4 days. So it was very reasonable, between 4 to 6 days that we would have the results, and we're able to randomize patients to receive treatment. I just want to point out that once patients are randomized, basically make sure that once they're randomized, it's very short period. They should start within 7 days to start the treatment treatment afterwards. The screening accrual completion was 66.5% with a Schlafen-11 positivity rate of 64.9%, which is higher than what we expected. We expected around 50%. And basically the accrual completion is 67% to date. As of yesterday, we have still 63 patients that are randomized to our study. We do encourage everyone to open the study and to consider patients, especially now it's sort of like a biomarker driven and a predictive factor that can guide treatment in small cell lung cancer. Hopefully we can get there.
Perfect. Thank you very much. All right. So I believe that Dr. Al-Jamali is joining us virtually. So we'll have him give us a quick update on S1933, please.
Yes, thank you, Dr. Gray. Yes, I'll give an update on S1933 and pilot study of hypofractionated radiotherapy followed by atezolizumab consolidation, stage 2 or 3 non-small cell lung cancer patients with borderline performance status. Next slide, please. So the target patient population of this study is stage 2 non-small cell lung cancer patients who are not candidates for surgical resection, or stage 3 patients with performance status 2. So this is a patient population that we don't have evidence-based data to guide treatment decision because those patients were excluded from the randomized phase 3 studies that set the standard of care for stage 2 and stage 3 non-small cell lung cancer. So patients receive hypofractionated radiotherapy, 60 gray and 15 fractions, 2 to 5 weeks after completion of radiation. Patients get repeat scans, and patients with no disease progression go on to receive atezolizumab consolidation for up to a year. Next slide, please. The study is currently open in more than 100 institutions around the country. In terms of enrollment, we are almost halfway through enrollment. We've been doing better with enrollment over the past few months. So thank you for everybody who enrolled. And I encourage everybody to remember the study when we see this patient population. Those patient populations are there. We see them in the clinic. So please remember the study. One question that came a few times from other sites, DLCO, we had discussion with our radiation oncology colleagues. And the study requires more than 50%, does not specify absolute DLCO, so adjusted DLCO for hemoglobin or alveolar ventilation is allowed. And I'm happy to answer any questions or if there are any suggestions to kind of enhance enrollment so we finish the other half of the enrollment.
Wonderful. Thank you very much. We'll hold the questions to the end, and we'll have Dr. Megan Daly come give us an update on S1914, please.
This is the update on SWOG-NRG S1914, a phase 3 randomized trial for early stage medically inoperable non-small cell lung cancer comparing radiation alone to radiation with atezolizumab. This is the schema for S1914. The control arm is standard of care stereotactic radiation. Currently, 3 to 5 fraction regimens are allowed, although a pending amendment will also allow 8 fraction regimens, which we hope will make it easier for investigators to enroll patients with ultracentral tumors. The experimental arm includes neoadjuvant, concurrent, and adjuvant atezolizumab given for a total of 6 months, or a total of 8 cycles. And our target accrual is 480 patients. Our current accrual is actually 91 out of the target 480 as of this morning. Oh, I don't have the rest. So just a couple of other key points I wanted to mention. I had a few other slides in here. We do have a pending amendment for S1914 with CTEP that we hope will be active within about a month. And that amendment will, as I already mentioned, allow 8 fraction regimens to be considered for patients with challenging central tumor locations. We will also be allowing multifocal tumors to enroll. We've had a number of questions from investigators about T3 tumors, and because that's a very frequent presentation in this population, we're hopeful that that will also open this trial to more patients. Our amendment also clarifies some frequently asked questions that we've gotten with regards to the blood draws and the timing of follow-up assessment CT scans, and removes the requirement for specific DLCO and FEV1, given that there's not really evidence to support that's necessary from a safety standpoint. So we're hopeful that that amendment will make it easier for patients to enroll in the trial. We are planning on having an investigator meeting as soon as the amendment comes through in a virtual platform. And just one other note for any sites that are trying to decide whether they'd like to open 1914. There are 2 competing trials in this space with fairly similar designs, but we believe there are some aspects of our trial that are particularly friendly to patients if you're trying to decide between the studies. In particular, the fact that we do not have a placebo control and that we do have a shorter duration of total immunotherapy, only 6 months as compared to between 1 to 2 years on the other trials in this space. And please feel free to reach out to me at any time or to Chuck Simone from NRG if you have any questions or if there's any other concerns about the trial or things that we can do to make it easier for your patients to enroll. Thanks.
Perfect. All right, and Dr. Ann Chang will give us an update on the Insignia trial.
Thanks. This trial is halfway through, almost halfway through. We're really excited about it. I've been at so many venues where the answer to talking about some real-world data was we really need to prospectively answer this question of whether or not you can start with whether or not you can spare chemo in the first blush, and then the other question, which isn't really being answered in any other specific trial at this length, which is treatment beyond progression. Can you add chemo to pembrolizumab to have the same effects? So I think that thanks to our SWOG sites, I looked into, so our SWOG numbers are less than the ECOG numbers, and I did look into this because, for example, at Yale we put 16 patients on, but 10 are counted as SWOG. So if you look at your numbers and they don't match up, we want to make sure that we are capturing the SWOG involvement. And I do want to say thank you to many of you here, Dr. Suga, I see, who have supported this. First, some updates. We have an amendment now that is almost ready to go in to address a number of house cleaning things. But as Nagla said, we are going to allow EGFR mutational analysis by liquid biopsy. I mean, we do want the tissue, but we understand that sometimes you really need to make quick decisions. We don't think we can forego that because it is a molecularly driven trial. We have the TM part of it that we're going to gear up to look at the immunosignature, and we don't think that if you truly have a driver mutation, that single agent IO is the way to go. Hopefully you're getting Twitter posts about Insignia. As Dr. Hesketh said, we're utilizing MedNet to really understand some of those barriers. The toxicity so far, really no flags, and we're planning some webinars coming up in the spring. If you have any comments or input for this trial, please contact me because we're putting in the amendment next week, so this is a perfect time for that. Thank you very much.
All right, great. Thank you very much. All right. Okay, so Dr. So could not be with us today, so I'll give a quick update on S1701, which is looking at locally advanced recurrent or metastatic thymic cancer. So this study is a phase 2 study that's looking at treating those patients with no prior therapy and giving all the patients carboplatin, paclitaxel plus or minus ramucirumab, and then followed by ramucirumab maintenance if you are enrolled into that arm. thus far, one of the reasons we wanted to present this study is that we need help with accrual, and right now there's 16 out of 66 patients enrolled. And so we know that this is a rare patient population, and so if you see any of these patients at your site, please do consider this trial. And very similar to what Dr. Chang said, if anybody has any ideas on enhancing accrual and building awareness around this, she's very open to this. And you see the primary endpoint there is progression-free survival. All right. And so we'll have invite Dr. Goldberg up to give us an update on this ECOG study, please.
Hi, everyone. So I'm going to very briefly tell you about this trial, which I think you probably all know about already, but just as a reminder. So this is a trial out of ECOG. Helena Yu is the study chair, and I'm the SWOG champion. I'm going to skip the background and just go right to this. So this is a randomized phase 3 trial for patients with EGFR mutant non-small cell lung cancer in the first-line setting. And so the randomization is to osimertinib, our standard of care, of course, and that is versus osimertinib plus bevacizumab. So the primary endpoint of this trial is progression-free survival, and the goal accrual is 300 patients. So this is, I think we all know that the data that this is based on. There's good evidence that the combination with an EGFR TKI and a VEGF pathway inhibitor can improve progression-free survival, but it hasn't been well studied in the setting of osimertinib. So this is an important trial. There are many competing studies in this space, but my understanding is several of them will be closing soon. And so if there is space in your trial portfolio for a first-line EGFR trial, I think this is a really great one, and it has been challenging with accrual, and the numbers are low, especially through SWOG, so it would be great to have some more participation. Happy to take questions later on. Thanks.
Great. Perfect. I think that's it. Okay. I'll take it. Yeah. All right. And so, thank you everybody again for giving all the update on those open to accrual trials. I don't see any questions in the chat currently, which means that everything was very clear and everybody's enthusiastic and has these trials all open at their sites. Anybody want to, any questions in here in this room? All right, perfect. I think we will invite our second scientific speaker to please come to the podium. So I think many of us know Dr. Westuba, who also just spoke at our recent plenary here in translational, on translational medicine. So Dr. Westuba is professor and chair in the Department of Translational Molecular Pathology with joint appointments in the Department of Thoracic and Head and Neck Medical Oncology. He's also the director of the Khalifa Institute of Personalized Cancer Institute at the University of Texas MD Anderson. He holds multiple other hats, including director of Thoracic Medical Oncology Laboratory, director of the UT Lung Spore Tissue Bank, MD Anderson Institutional Tissue Bank, and director at ECOG Akron Central Biorepository and Pathology Facilities. Within the SWOG Lung Committee, he is our key pathologist, and he will be speaking to you today about immuno-oncology biomarkers in lung cancer and talking to us about the CMAC-CIDC network. Dr. Westuba.
All right, thank you, Dr. Gray, for the introduction, and thank you for the invitation to speak today and to be in my first meeting in person in 2 years. And also I would like to thank the previous speaker to give me the opportunity to speak for 45 minutes. Just kidding. I will try to contribute to the saving time so everybody can, leave and get in time to the airport if you need it. So these are my disclosure, and the other important disclosure is that I'm not an immunologist, and I'm struggling with it. So if you have any good immunology question, I hope we have some help here in the audience to assist me. So, and I have this slide. I've been building on this slide for many years, and now it has like 7 bullet points, which is great for lung cancer, right? And bullet number 4 is still, the need for biomarkers to predict response in patients treated with immunotherapy in lung cancer, particularly those receiving immune checkpoint treatment. And this is a slide from my friend, Dr. Kurt Schalper, that many of you know. And this is like 5 years old slide, but it hasn't changed much. We still have PD-L1, as the best predictor in this immune checkpoint inhibitor. Of course, we have MSI, and mutational burden is on the edge, right? We want all translational and clinical investigators in the immune analysis of tumors and patients treated with immunotherapy be as comprehensive as we can. Hopefully longitudinal, which is key, in my opinion, to understand the evolution of the immune response in the tumor microenvironment and the effect of the intervention, which is a really challenging topic. And then being patient-centric, because it's not just the tumor, the immune response in the tumor, is the host has a very important component to keep in mind. And a very old slide, you have seen a lot. I use this to highlight that as we have dealt with genomic understanding of tumor and tumor evolution in the past and interventions, I think that we need to interrogate the tumor and for the immune response in immunotherapy. And then when we understand what's happening in the tumor, hopefully we can take some of those understanding and develop surrogate biomarkers or real biomarkers in the periphery, which means blood, cells, serum plasma, and fluids, or other samples from our patients. So this is a slide that I shared from one of the co-PI for the CIMA network, and I'll get to that in a minute. For people who haven't been able to see the plenary session, I have a few slides on the CIMAC, is that we try to be comprehensive in tumor analysis with merging immunology technology with genomic-based approach. So it's been a great experience for genomic-oriented people learn about immunology, and immunologists also get in the genomic space. And this is a slide that we have developed in our platform in MD Anderson that I co-lead with Dr. Andy Fuchal, in where we're aiming for a comprehensive collection of specimens in patients treated with immunotherapy, mostly, in which we're trying to be prospective. Actually, we have a platform that has collected baseline and on-treatment patients, over 2,000 patients in 65 clinical trials. And then with a very mindful collection plan of tissue, blood, and other samples, have a comprehensive analysis that have some minimal assays run in all samples, if possible, in all patients regarding clinical trials. This is a slide that I developed a couple of years ago. The top 10 remind me, Dr. Roy Herbst's approach to things, important topics to design immunotherapy trials. And I know that it's in the mind of all of us. I'm not going to go through the list. It's in the mind of all of us to be comprehensive, longitudinal, but there are many barriers in our network, right, NCI network, to be able to do that. And being longitudinal on tissue collection, it was raised before, is extremely difficult, but we have some other opportunities. So with all this background on what we all would like to do, and in some places is happening, the NCI launched 5 years ago, I believe, 4 or 5, this CIMAC-CIDC network. CIMAC stands for Center for Immune Monitoring and Analysis for Cancer. And there is a partner in the CIDC, which is a Center for Immunology Data Commons. They actually a place that holds the data and help us to do analysis, and in the future, inter-trial analysis. And this network, it has 4 CIMAC sites. Stanford, the PI is Holden Maker, Dana-Farber, PIs Kathy Gu and David Hody. Mount Sinai, PI Sacha Nyatik. And then the others, so we have 3 PIs, an immunologist, Kara Heimaker, a clinical investigator, Giyad Alatrash, and myself, who is the contact PI. In Dana-Farber, the PI is Ethan Serrani. It has been a very interesting experience, highly collaborative, collegial group. We built the network. We faced a lot of challenges, and we're going through. we're running out of time. Our official funding ends mid next year, but we still have one no-cost extension, and we are working with NCI supporting a potential renewal under the NCI Moonshot program that I heard was renewed, right? We serve the NCTN network of clinical trials, and we have, including people that have potentially NCI R1s, PO1s, spores, and also we have a guest, the PACT Alliance. PACT is, I forgot in this slide to have the detail on the acronyms, but it's a partnership between academy and NCI, no, between academy and companies. But it's basically a partnership between NCI and 10 pharma companies that decided to support efforts like this. And because they're bringing their own clinical trial to our network for us to run the same type of biomarker that we're doing for the other trials. And it has been a very successful partnership. It's run by the foundation of NIH, and that's actually the path that we used to get the lung map S1400I cohort in our MD Anderson CIMAC. I'm very happy to do that. So I'm not going to go about the description of the mission of this CIMAC network or CIMAC CIDC network, but the idea is to do immune profiling in clinical trial, being exploratory and multidisciplinary in the approach. Again, another how this network is built, NCI and PACT all together, working with 4 CIMAC, 1 common data center. Samples are coming from the clinic, from the tissue banks from each of these oncology groups, and which has been a challenge, but I think that we're doing well now. So one of the first things that we did is we put together a kind of portfolio of assays that we look to run in samples from patients, and we divide in 3 tiers, tier 1, 2, and 3. Tier 1 is for all or most trials. We had to develop an alternative approach to some of these analyses based on the quality of the sample that we had. So the tier 1 assays are whole exome sequencing, multiplex immunofluorescence, or immunohistochemistry and PD-L1 immunohistochemistry in the tumor, followed by RNA-seq. And in the tumor and also in peripheral mononuclear blood cell, TCR sequencing, you see adaptive approach. CyTOF, flow cytometry is an alternative for peripheral mononuclear blood cells. For cytokines and growth factor, we have Olink or ELISA approaches and Luminex as alternative. For genomic analysis, especially to follow up patients, we have NGS panels of cell-free DNA and microbiome with added. Tier 2 and Tier 3 are more exploratory assays and platforms that have been, been incorporated because all this was planned 4 years ago, and the technology evolved, and we need to be up to date. So we have selected trials in which we're doing prospective collection in the network that we are doing more advanced methodology, including single-cell approaches. The second, we had to take our tier 1 assays and harmonize them. It was a requirement of NCI. We were not aware of that, so we spent 2 years and a lot of resources harmonizing between 3 and 4 sites, depending on the availability of the assays, RNA-seq, whole exome sequencing, and the interpretation, CyTOF on peripheral mononuclear blood cells, and 2 multiplex technologies, multiplex immunofluorescence and multiplex immunohistochemistry, and all these papers were published together jointly in Clinical Cancer Research in 2021. We also developed an umbrella protocol with SOP for sample collection that's available in our CIMAC CIDC website, that anybody can download it and look at it, because it's very comprehensive in terms of what the best practices to collect, process, transport specimen for the assay that we have been studying. So by 2021, we have 33 clinical trials, and we were actively working as a network, and 26 more planned. And we're expecting to have close to over 3,700 potential patient study at the end of the 2 more years to go, and these the modalities are there in this pie chart of the 33 clinical trials. Many of them have, immune checkpoint inhibitors, and there are some other, immunotherapy options there. These are the trials that actually in November we were doing analysis. Many are coming from a clinical trial network, few from PACT, and then the number of projected samples per trial. So you can see 100 to 1,000 in some trials. And then we have the 2 SWOG that we are been working on, the DARTS S1609 trial on rare tumors. I presented some preliminary data in the preliminary session last Thursday, and today I'm going to focus on the cohort S1400I. So, and I'm doing fine on time. Great. So, so this is the figure of the S1400I phase 3 randomized clinical trial reported in JAMA Oncology in 2021. You are very familiar. This is a Nivo plus EP versus Nivo in previously treated patient with stage 4 squamous cell carcinoma. 252 patients were treated, 125 with Nivo plus EP, 127 by Nivo alone. And the results show there is no difference by the 2 regimens, while there is a little bit of advantage you can see at the end of the tail of the curve on the combination arm. So, and this trial had biomarkers included for the screening of the patient, the lung map, that you know very well, Foundation Medicine NGS panel, and PD-L1 immunohistochemistry in CLIA setting. And they have some analysis pre-planned, pre-specified on PD-L1 immunohistochemistry levels and TMB using a specific cutoff. And then they have a post-hoc exploratory analysis using expanding the different cutoff. And by this post-hoc exploratory analysis, as was published, there was a finding of improved overall survival in the combination arm over the single arm in patients with tumor mutation burden higher than 10 mutations per megabytes, and a PD-L1 immunohistochemic expression less than 1% in that particular group. And this was actually the same biomarker with detriment in patients that had less than 10 tumor mutation burden. So now CIMAC comes in, and from over 250 patients, I believe, it's more than 250, right? We had to see what we could do on exploratory basis using our, tier 1 biomarkers analysis. So we came up with the hypothesis. I'm not going to read it. It's very exploratory. So we've checked that box, having a good hypothesis to do exploration. And then we look at what samples were available. We found that some remaining formalin-fixed paraffin-embedded tissue was available. So we thought that we could do a good multiplex immunofluorescent analysis to panel 14 markers. And after we went through the samples, 82 only qualified for that. So you see the attrition level that we're facing in those CIMAC trials that are using samples already collected. We went to nanochain RNA expression because forget about the quality for RNA-seq. And we have a panel of 700 immuno-oncology-related genes, and 38 samples went through that analysis. We are finishing the whole exome sequencing analysis of 50 pair samples, normal and tumor, available from the FFPE. And then we have blood, we have plasma in these patients, and those are being used for Olink analysis, which is a cytokine analysis of 160 markers run by Mount Sinai, CIMAC, led by Dr. Nyatik. And our group actually did the multiplex, the nanochain, and the whole exome sequencing, and in collaboration with the clinical investigators that have been great partners, and we appreciate that, and the support of Dr. Redman, Mary, who has been tough on us, but a great partner to get the right data presented. We have been able to get response rate, overall survival, and progression-free survival. I had a lot of Zoom calls. Actually, I can describe what is in the background of Dr. Redman, and I can actually describe how she aligned her clothing, her shoes in her apartment. So that's the level of collaboration that we have had. Sorry about that. But it has been a great collaboration. I will continue. I'm not the only one that made that observation. So then, in the chart on the right, you can see that only 36 patients have all these biomarkers done, which is a pity, right? But let's see what we have found. And this is the just description of 82 samples that we did the most. 35 had the combination Nivo-IP, 47 Nivo. And then we ran 2 panels of multiplex immunofluorescence. Our group actually had a lot of experience. We have run more than 10,000 specimens now for different collaborations with these 2 panels. We have 4 instruments in a large group of people doing this type of work. And we can study, single marker or combination of markers per cell, and we can do location by stroma or tumor. And also we can do a spatial analysis to show you later. For analysis, we predefined 17 cell phenotypes using our panels on malignant cells. Malignant cells present PD-L1, a combination of T cells and macrophages, and with different type of phenotypes. I'm not going to go in detail. So the data from the analysis, having all the 82 samples together and divided by arm, 35 in the combination, 47 in the single arm, we have found that several phenotypes correlated with outcome in terms of progression-free survival or overall survival. The one that I would like to highlight first is, I'm sorry about the business line, I don't have good animation because Dr. Grace, she's very good, very tough. She got my slide by Monday. So I have to send whatever I had at that time, and I apologize for the bad animation. But first, we found in the Nivo arm that there is several memory-related T cell or T cell with memory features that actually higher density in the tumor, either stroma or total in the tumor, in the sample, correlate with better outcome. And for the combination for the Nivo-IP, we found that the regulatory T cells that is shown here in the Kaplan-Meier curve, the higher density actually correlate with worse outcome in the patient treated with the combination. Overall, we found that higher density of various immune cells detected in the stroma and were detected more in the stroma than in the tumor. I didn't mention that, but we are trying to focus on what's different between the arms, and these are the first round of observations. But as it was shown before by the previous speaker in a scientific session, it's not just about the density of the cells. It's the location of the cells and how they interrelate to the malignant cells or to each other. And multiplex immunofluorescent technology and others like Codex, MIVI, or CyTOF imaging, or the new NanoString digital spatial profiling that we have, in which we can combine 40 to 50 markers in one assay. Multiplex immunofluorescence also allow you to do a spatial analysis. So from these 17 phenotypes, we studied the distance of those cells to malignant cells to each other in different compartments of the tumor in this population. And we have few observations that I'm sharing with you. First, we found that as closer the cytotoxic T cells that are activated are to the malignant cells, the patients treated with the combination Nivo and IP have a better outcome. This is not happening in the Nivo alone. And the same kind of observation now with cytotoxic T cells, if they are closer to malignant cells that are PD-L1 positive, we see the same kind of benefit on outcome. And this is not seen in the Nivo arm. This is only the combination. This is another slide that, if I had time to revise my slide, I would have deleted. Because it's actually, you find in these kind of correlative studies sometimes findings that are hard to explain from the biology and from the immunology. And many times it's because the technology they're using is not giving you the complete response. This is few markers to classify immune cells that sometimes need more phenotypes to actually to be more specific. And in this case, it's showing that in the combination arm, when you have memory T cells that are classified by expressing CD4 45 row, actually closer to the tumor is it has worse outcome. We're not sure what type of memory cells are these. Could be potentially regulatory memory T cells that potentially could explain this association on being closer and being worse for a patient treated with Nivo-Ipi regimen. So, and in our CMAC network, I hope I could do this in the S1400I, but we're not accessing to enough specimens. I mean, there is not enough specimens available. We're moving, as I just mentioned, from multiple immunofluorescence to higher multiplex systems. So in one H&E from a formalin fixed paraffin embedded tumor, you can study your at least 40 markers. We have experience with all these assays. Some of them is very hard to combine more than 20, 30, but it's possible to get more data from this spatial analysis. Very briefly about the nanogene gene expression analysis using this immune profiling pattern of 750 tumors plus 40 genes, sorry, plus 40 housekeeping genes that we did in 38 samples from 15 treated with Nivo plus Ipi, 23 with Nivo. And first, what we look at by using this technology, if we could find some immune cell, because there is a software that allows us to kind of quantify the immune cell infiltration based on the RNA expression that you get. And we found that in the responder in this particular arm of the trial, it had an increased number of CD45 T cell neutrophils and exhausted CD8 T cells. This is our very preliminary data, and I think that is something that we need to keep exploring. With this gene expression analysis of the immune oncology-related genes, these are, again, 38 samples only, and these are all samples combined, and we identify a group of genes that were associated higher expression with better outcome of the patient, overall survival, and these are genes associated with myeloid infiltration, immune recruitment, and inflammation. There are 3 genes here that I'm highlighting. And also we have genes associated with worse outcome in the entire population, and the one that we're highlighting is associated with apoptosis or MAP kinase pathways. This is very exploratory, few samples. We are thinking how we can actually hopefully validate this in other cohort. We have new adjuvant trials having this combination at our disposal. So we'll see in lung cancer, so we'll see if we can actually be able to establish that collaboration. I'm gonna go quickly. Just to summarize, despite sample limitation, our findings showed the potential of biomarker exploratory analysis in immune therapy-treated patients using a team science approach. In patients treated with the Nivo-Ipi arm, but not in the Nivo arm, higher density of activated T cells in the tumor compartment were associated with better progression-free survival and higher density of stroma regulatory T cells with worse survival. The immune spatial analysis showed that the presence of activated T cells close to malignant total cells and PD-L1 positive cells was associated with better outcome in the patients. And we found some genes, as I mentioned, that were associated also with the outcome in this population. I'm going to go into detail, and I didn't show anything about the Olink cytokines analysis, but there is some interesting data emerging from the variation on the expression of some cytokines over time, because for this trial have a good collection at baseline at several time points, and we're looking at variation of cytokines in the plasma and serum of the patient, how that correlates with response. There are some preliminary data that are going to be shown at AACR and ASCO this year, but I didn't have time to go through that, and it's, to be honest, it's something very hard for me to understand. So next steps, very briefly, is a abstract presentation, summation, ACR and ASCO, manuscript with all biomarkers, highlighting, in my opinion, the best story that we have, which is the spatial analysis, and it's in preparation, and I'm happy to be able to report to this group some collaborative work between CIMAC and the Lung Cancer Committee that I'm very happy to be a member of. Thank you very much. Before I go, this is showed that in our CIMAC, MD Anderson, we have probably 20, 30 people with different expertise. I already mentioned our co-PIs, Karl Heimaker, Yala Trash. I would like to highlight the work of Edwin Parra on the multiplex immunofluorescence and Ziva Duose on the nanochain work. CIMAC CIDC resources, and then thank you very much for your attention.
Fantastic. Thank you very much. We'll open the floor to questions, and if I may kick one off. So you ended the talk with going over CIMAC and talking about the lung collaborations with the lung committee, and I'm looking at Phil here, right, our head translational medicine lead. So I'm an investigator. I want to work on opening a trial. If maybe the two of you can talk about how do you work together in partnership, and how does an investigator kind of walk through that process with the very complementary roles that you both have?
Yes. Yeah, no, I'm happy to do that. We have done that a lot because we have built not only the network, we have actually learned how to run a network in the context of a clinical trial, the NCI clinical trial network, right? So unfortunately, because the success or the interest of people in this network, we stop accruing new trials like 2 years ago because we didn't have enough funds actually to do everything, right? So we stopped taking new trials. But PACT, this partnership with pharma, not, and they keep coming. And for our network, actually, they come with their own budget. So they're not eating our NCI budget, which is good. So some people may have different take on how to approach this because, pharma are getting a good deal through NCI. But, it's true that these trials are sponsored by pharma, but they are developed by clinical investigators like you, right? And you go to pharma to get support. So I always take it that way. So our CIMAC at MD Anderson is actually taking a lot of PAC trials. And that could be a way to potentially be able to analyze new trials in the next 2 years. And I'm happy to help with that. And also advice on how to deal with specimens that are coming from our NCTN biobanks that we have learned a lot. I'm a banker. I run the EcoGacrin Bank, so I know the limitation that we face, but I think that by actually being a banker and then a CIMAC investigator, I could help. I was able to help a better turnaround time and more collaboration between the banks and our laboratories.
Great. We can hear from Dr. Mack and then Dr. Hirsch.
Yes, I will not give quite as roundabout an answer as that, which is basically to say that we are anxiously awaiting incorporation of CIMAC assays and programs into our studies. Okay. And the moment that we are able to do so, we will do so. And just to put that in context, if you think about LungMap, we have, not whole genome sequencing, but we have very expansive mutation cancer panels that are professionally done and give us a lot of information. What we are absolutely lacking, especially considering the number of IO-type studies that we have, is a suite of IO-based markers that will be informative. Mm-hmm. And it's something that we had discussed up front when it became clear that a lot of LungMap is going to be based on IO-type therapies, that we should be incorporating a lot of these things as early as possible, even if we don't completely understand them, so that we'll have a good basis. Just think of like all the other mutations on the panels that we never look at. They're there for us to explore, and we've kind of wanted this. But I think Dr. Wistiba's talks both today and a couple of days ago just indicate what an amazing challenge he is faced with in terms of just the monumental amounts of harmonization and quality control and pressure from various entities to put something together. Okay, I guess I am giving a long roundabout answer. We very much want to work with CMAC at the earliest possible and incorporate them in as prospectively as is reasonable for the amount of tissue that we can give to them.
Perfect.
Actually, what you were talking remind me that the harmonization work is something that was very contagious in our group. Do it, not do it. I push it because I realized if actually we had this harmonized and published, we have CTAP pre-approving everything that we do in terms of this biomarker. We go through CTAP without any question if this tier 1 harmonized, assay. So, but hopefully we can continue doing work in this network to capitalize on
Let me
that.
put it very succinctly. We are grateful that there's a lot of expertise out here attempting to put together a quality suite of something that's extremely complicated, and we are waiting patiently for them to be able to put that together and implement it clinically.
Great. I mean, it sounds like it's going to be a really wonderful resource, and we appreciate all of your efforts and collaborations. Dr. Hirsch, did you want to add anything, or provide you an opportunity to talk? And then I think we have 2 questions.
I want to concur what has been said, but I'm sitting back with one question, which is probably to Mary. I'm not a biostatistician, but you show all those hazard ratios for very interesting combinations. And for the same study, we have PD-L1, we have TMB. Is it possible to make a multivariate analysis and see how the different concepts ranks together?
Do you want to go back to that slide?
I think that, the CMAC team has all that data as well. So
Yes.
I think the first step was to look at just the single associations and then look at all of those things together. But it's limited by sample size.
Yeah. Actually, some of the data on the immune infiltrate correlate with TMB. I haven't presented that, but they're part of our preliminary, maybe some of the abstract and in some of in the preliminary draft of the paper that we have. TMB, we have looked at PD-L1, hasn't been useful at all.
Yeah.
Very interesting.
Yeah, we have separate analysis on PD-L1 and TMB, but it would be interesting to see how they combine together.
And also, now we're looking the patient, the tail of the curve that actually showed the improved outcome in the Nivo EP, right? Right?
I need to follow up with Jack. There's a question.
Yeah.
But yeah, they were trying to determine how to do that.
That's great. That's exactly what
Thank
we
you.
need. All right. Microphone, we'll go to microphone 2 maybe, and then back to microphone 1.
Hi, thank you for that wonderful talk. I'm Diane Singh from Fred Hutch, and a medical oncologist and previously on the Stanford CMAC team before coming here. I'd love to hear more about your vision for the CMAC and kind of presuming that it will get renewed, and whether sort of your vision is kind of to do analysis to complete the existing, or complete the existing analysis of the trials that you've already committed to, or whether you see there are sort of new opportunities for new concepts and new trial correlates.
Yeah, thank you. Thank you. As I mentioned in the plenary session, the commitment now is to do the 33 plus 26 trial that we have acquired. And that is, we have 1 year, close to 2, with 1 year no cost extension. That's the commitment. And we are saving all the money so we can complete that. In the meantime, my vision is that we should take as good packed trial are available, because that's going to keep us going, maybe an additional time if the network is not renewed. I'm optimistic that the network will be reviewed. We are providing whatever NCI needs actually to make their case, but this is funded by the NCI Moonshot program. They are funding a lot of other programs. Many of them are more basic research. They have spectacular publication records. And it's very hard to compete when the best that we can show is harmonization of trials in clinical cancer research, right? It's a great journal, I like it. But I'm optimistic. I'm very optimistic. I'm an optimistic person, so I don't know, maybe you can ask Sasha. He always counterbalances me. I'm optimistic. I think it's going to be very new. It would be a waste of expertise.
Yeah, it's a great resource, again, for the investigators as well as the patients. Yeah. Microphone?
Yeah, so I'd like to comment all your efforts, a daunting task to have all the parties working together, clinical investigators and different collaborators across different institutions. It's a really big task, so I want to appreciate all you do. And my experience working as a PI from the DART side, rare tumor trial, it's been all positive, and just looking forward to similar things happen in other trials. So because I'm one of the PIs in DART, we're looking at markers not just in one histology, what also applies to across different histology is what we're interested. But looking at the whole CMAC profile of the trials that are involved, you could actually look at, because the frustration is like the 36 patients, right? But then if you get all the CMAX trials all across different histologies, you can do more like a pan-tumor analysis because you harmonized all the sets, platforms, and then you have all different tumor types, not just the DART, but across different GU, GI, lung, and rare tumors all combined. So I see the future that there could be higher end, which enables more exciting work to be done. So I'm very excited for that opportunity. And happy to be involved in any of the research, about those pan-tumor markers as well. I have a specific question for you. Is that tumor cell and immune cell, the distance, that's a really interesting topic, and I do think it's a phenomenon that can be validated across different histologies and so forth. But how are you, and I know other companies, commercial sectors looking at the same things. In your group, is there any lessons or insight you've learned in terms of applying AI, or because you haven't done manually? So what is your thought on how the best way to apply AI in these type of research?
Yeah, no, I think that H&E stain slide, immunohistochemistry stain slide, multiplex immunofluorescent and immunohistochemistry stain slide, and the higher plex system stain slide all offer an opportunity to apply computational pathology. I call it digital pathology. I know then you have image analysis, then you have machine learning, and then you have AI. I know many people jump from digital pathology to AI. It's a process, but all these images are data that can help us to get answer on immune response and other abnormalities existing in the tumor. So we are very much interested to do that, and we are exploring at every single level of imaging available, starting from H&E. And the images, the H&E of all these trials, fully profiled, are going to be available. We're opening inside the CMAC some requests for application for inter-trial analysis. And the first one came from Olink, 160 cytokines and growth factor ran already in over a couple of thousand samples from these clinical trials. So that's going to be the first one. And hopefully we have the opportunity to do the same with multiplex and other technology in the future.
That's great.
Right on target. Thank you.
Great information. Thank you.
Are those applications, are those solicitations come out of a
Are
specific
internal at this point.
Internal, okay.
Yes.
Okay.
Just to
And I think Dr. Chang has a question.
One more question, yeah. Comment, really impressive work, really amazing and so important. We'll be talking to you offline about Insignia and how we could perhaps capitalize on some of that information. But my question to you is, do you have any juicy tidbits or thoughts about how dynamic the environment is, and looking at different points in time or different, disease states, in other words,
Yeah.
resistance and so forth.
Yeah, I'm very much interested on that. I have done that a lot, that type of work on genomic analysis in the past with post-treatment biopsies. Now, I think that, in my opinion, the field of immuno-oncology is going to advance faster. We're able to get more on-treatment biopsies on patient treated, when to be, what's the right time. We had a lot of debate because we have this Apollo program institution that we get mandatory on-treatment biopsy to be supported for sample collection and analysis. So that's why we have a couple of thousand of those. I think that we have came up with 3 to 5 weeks, depending, that fits most of the treatment that patients are having. And I've seen in sarcoma trial, for example, tumors that are completely cold, that you weren't thinking about immunotherapy. After 2 cycles of immune checkpoint inhibition, a subset of those, but some certain subtype of very rare sarcoma trials actually are not cold anymore, and you see an incredible response. We have pending publication on several rare tumor sarcomas that actually there is a response about 40–50% using a combination of immune checkpoint inhibitor. Patients that the only thing they get is surgery or chemo radiation. We published a paper on mesothelioma. I'm fascinated with rare tumors. If I start my career with work only in rare tumors. Mesothelioma peritoneal, 40% response with immune check inhibition. A patient that don't have other hope. So, and we identified some biomarkers that tell us which one are those responded. It was published on Cancer Discovery a couple of years ago. So there is a lot of we can learn with on-treatment assessment. Biopsy for now, or hopefully surrogate markers in the future.
Perfect.
All right,
Thank you very much, Dr. Estuba. Great. All right, and thank you very much, everyone, for joining us here today, and we'll see you in Chicago. I do want to give a special thanks. I see online we also have a lot of our protocol team and coordinators and managers, Mariah, Crystal, Laura, Jennifer. Thank you guys also for making these trials happen. They would not happen without you. And I wish everybody safe travels back home. Thank you. Good job. Thanks.
You did it.
You did it. Done.
Well, I mean, in addition to the fact that it was a good meeting, one of the best characteristics of the meeting